Testing, testing. Hey everyone. Please grab a seat. We're about to start our program. All right. Good morning, everyone, and welcome to the 45th Annual Legislative Breakfast on Mental Health. My name is Max Shafir, and I'm the chair of the planning committee for this event. I'm grateful that we are finally back in person after 2 long years of being virtual and not being able to enjoy the delicious food that we have here today. I want to thank everyone so much for bringing back such a strong presence to this event. With everything we've been dealing with during this pandemic, it's nice to see old friends and new faces. This year's theme is one that we all value within the mental health field. We focus on why we need legislation and policy that effectively supports comprehensive community-based care. Now, what does that actually mean? The entire purpose of this breakfast is to bring in legislators, MCOs, PHPs, providers, and clients under one roof and sitting at the same table, so we can have real-life conversations that can create some actual change in North Carolina. We're here to provide education, collaboration across deeply rooted individuals within the community and help one another out. We are here to make things better. So here's what I'd like you to do. Take a moment. Think to yourself, what kind of change agent you want to be, and how can you make this happen? We have some very influential figures in the building today, all of which are here because they value their commitment to mental health in North Carolina. So take the opportunity, start a conversation, maybe even start a partnership. This is your opportunity to get to know someone else outside someone that you actually attend the conference with. So please, pause, take a moment, reflect, learn something new, and go be that active agent of change that you want to see in the community. We have a wonderful program planned for y'all. Our list of amazing speakers includes experts in the field of mental health, legislators, lived experience panelists that are going to focus on core topics around early intervention, prevention, transitions, and continuity of care across the gamut of ages. I want to give a big shout out and thanks to our speakers, panelists, and legislators who are playing active roles today, as well as our planning committee who spent a lot of time organizing this event. We can't forget our sponsors. Without them, this wouldn't be possible. So I also want to give them a big round of applause as well. Probably should have waited till the end because I've got 2 more people to thank. I really want to thank the National Association of Social Workers, the NC chapter, Valerie so much for all the work that she's done partnering us with this program. And finally, one big shout out to the Friday Center because they've dealt with all the changes that we've made last minute, dealing with all of our difficult questions, and they've done an amazing job. So one big round of applause to wake us up this morning. Now I'd like to introduce a very key central figure to this breakfast. Senator Mike Woodard has made this job look easy after 5 or 6 years being our MC, and maybe it is for him now. Not only has he been our MC, but he's actually supported us for over a decade, advocating and being a strong support in the North Carolina General Assembly for us. So I want to ask him to help us continue to make actual change and continue to have these conversations with our legislators that are here today, the ones that are not here today, and continue this conversation ongoing after this breakfast. So Senator Mike Woodard, please come on over and get this program start rolling.
Good morning. Max, thank you, and thanks again to the committee for the invitation to serve as your MC. I'm like that bad penny. I keep turning up every year. But I'm always happy to do it. This is one of the things I look forward to each and every year. And what a big crowd today. Wow. It's nice seeing you in person, not on a Hollywood Squares box as we've been the last few years. I said that to a younger colleague one time. I said, yeah, it feels like Hollywood Squares. And they looked at me like, what's Hollywood Squares? So I didn't tell them I was the Paul Lynde of the Zoom or the Charlie Weaver. All you baby boomers will remember those guys right on Hollywood Squares. So, and it's wonderful to see such a great crowd. So big we had to move in here and change things up a little bit from being down over in the Trillium. Reminds me, my grandma was a gardener, and she had a cousin. If you're a gardener down east, you always claim there's a certain cousin, Ava, that everybody was kin to. My grandma was actually Ava's first cousin. And we got the word around Gardner's Township, we were having a family reunion, first big one we'd had in years. And word got out Cousin Ava was coming to town. Well, so we were there, we gathered, y'all from the country, you know those little Ruritan buildings where you can have all your family events and everything. So the gardeners gathered around waiting for Cousin Ava to come. Let me tell you what, we didn't know we had so many gardener cousins who wanted to see Cousin Ava. So all the young cousins my age, we had to go run up and down the road. We ran out of chairs. So anyway, Cousin Ava comes, we had a great time. But we were knocking on doors, getting chairs out of people's yards, their lawn chairs, their dining room chairs, any chair they had in the house. So we had enough chairs. So this is like Cousin Ava coming home. We got enough chairs today, though. So I am happy to welcome you all to the 45th Legislative Breakfast on Mental Health. And again, we're so glad to be back in person and dressed. How about y'all? I always had a nice shirt on the last couple of years, but I ain't going to talk about. I did leave my sweatpants at home today, so anyway. And as you all know, the challenges of going through the pandemic meant that we all had to become flexible and adjust. But those of you who work in mental behavioral health, y'all know that. That's your day, every day. But we have made adjustments. So the realities just, I think, heightened our awareness of the many ways individuals and families are impacted by the difficulty in accessing and receiving essential services. And that challenge continues even as we come through the pandemic and provides additional stress and with emerging issues. As Max touched on a little bit, we have great opportunities today to learn from professionals who are actively engaged in research and development of the evidence-based services for persons impacted by mental illness, to hear current and emerging proposals to increase access to services across populations and the lifespan, and of course, what working together we can all achieve here in North Carolina. Before we get into the main part of our event today, I want to join Max in recognizing two important organizations who are critical in coordinating and putting on our breakfast. Max mentioned them earlier, but the national chapter of the North Carolina chapter of the National Association of Social Workers who coordinate the registration. If there's one thing I've learned, if you need something coordinated, ask a social worker, right? So thank you to NASW for continuing to provide the registration and a lot of the logistical support. Max mentioned the great staff here at the Friday Center. We couldn't do this without them, the technical support, and of course, the great breakfast. So thanks to the Friday Center staff. If you see them walking around with their Friday Name Center tag on, just stop them and say thank you. And also to our sponsors, many of whom are up here, for their support, both cash and in-kind, that made today's event possible. Their names are around on placards and here, and please thank them if you see them working around as well. And the group I get to work with so closely, an incredibly dedicated group of folks who volunteer every year to serve as the planning committee for our breakfast. They develop the theme, coordinate the speakers, work out all the details in making our event possible. Max Shafir, who you just saw a few minutes ago, Karen Kincaid Dunn, Linda Foxworth, Elizabeth Barber, and Linda Atack. I was getting emails from Linda last night at 8:30. That's the details and how late things were changing. And that group did. What's that?
You promised not to tell.
No, I just wanted to give you a shout out, Linda, because that's the hardest working woman in mental health these days. So let's give them all a big round of applause. We're going to be on a tight schedule today to keep things rolling. So I'm going to limit all my dad jokes today and keep our introductions a little shorter. But do know that information about all of our speakers, if you want to read more details about them, are available on the Legislative Breakfast website and Facebook page. And we're also recording the event, so it will be posted later, and you can go back and revisit a section you want to hear more about or share with your colleagues. I'd like to invite all of our elected officials who are here today, if they would all stand, local, state officials, please just stand. We're going to recognize you as a group. So I see a number of my colleagues from the legislature that, and some of whom you'll hear from, our local elected officials. We are so grateful for you all coming, town council members, county commissioners, members of the judiciary for coming and being part of this. And I wanted to give a special shout out, now I hope she didn't slip away, but our congresswoman from the 4th Congressional District is here today. And as I said to her yesterday, I said, I am praying. You stand right there. You stand there. I told her yesterday, I saw her yesterday, and I said, Valerie, I am praying for you every single day. Y'all know what I'm talking about. So, Valerie Fouché, Valerie, thank you. Now let's get into the meat of our program. One of the things, as your MC the last few years, I've gotten to do is introduce Cody Kinsley. And if you've been around with us, you know that he and I have a running gag about hair. Senator Bergen's in on this too. And because if y'all remember, during the pandemic, Cody, who has beautiful hair anyway, let it get a little long. And anyway, that led to much conversation and a few jokes back and forth. And Cody even said something about this a few weeks ago if I was going to talk about hair. Well, let me just say, as our plans for the breakfast gelled, as our COVID restrictions became less hairy, I learned that Secretary Kinsley would be our main speaker. So I thought I'd get to the roots of our joking around, but I decided that I would stop teasing him about his hair because, as you all know, as our secretary, he is truly a cut above. I'm not done. Oh, I'm not done yet, Kinsley. No, seriously, I have fun. Jim Bergen and I have fun with Cody about his, well, we're both follically blessed, so, you know. Seriously, under that gorgeous head of hair, though, is what I appreciate most about Cody and his leadership. The brain he uses to lead our Department of Health and Human Services every day, and a little further down, the heart, because Cody leads with both. And that's what makes him such a great secretary and is what has led him to assemble such an incredible team in DHHS. And I don't need to tell you all what a great team we get to work with in that department. So I'm not going to run through Cody's resume. Many of you know it. We get the chance to work with him regularly. He has been amazingly responsive, and I just think has done an amazing job as our secretary. So please join me in welcoming Secretary Cody Kinsley.
Good morning, everyone. 45 years. I remember the first one. It is wonderful to be together and to see everyone. And, you know, I've been talking to some of you as we've been gathering, and I really consider this event as one of the main keystones of the year in the big mental health conversation. And I think we've all been speaking about mental health a lot. And while it's been 45 years, I do think this year is different. I think it's different because as we have emerged from the pandemic, we have heard from more and more people that would maybe have never spoken about mental health before as an issue. Some of you, this is your first time here. And you're finding the connections that people have and the passion that people have to try to bring to really changing mental health care and well-being in North Carolina. As I come here most every year as of late, and yes, I've been cutting my hair, I thought it would be a good time for me to recap over the last 12 months what we've been able to get done for behavioral health and resilience, one of our top priorities at the department. So here we go. In June of this last year, we launched 988 to much acclaim, the second highest answer rate in the country, second only to the city-state of Rhode Island. For the first time, people are not fumbling with their insurance cards to try to figure out who to call at the most critical moment in what could be their life. We've seen a massive increase in the number of callers coming out of that, and in particular, first-time callers, which reinforces to us that people did not know where to go and what to do at the most critical moment in their life. We also realize that's not enough, and we put out a suicide action plan that calls for significant more investment across the spectrum of care and services for reducing what is tragically one of the leading causes of death, especially in young children. We also said, you know what? We can't just be looking for when people know there's a problem and speak up as a problem. We need to treat mental health just as any other disease and do syndromic surveillance in the ED so we can stay ahead of the curve and try to find out what's going on. And so we have leveraged the intelligence that we're able to gather through syndromic surveillance where people show up in the ED expressing certain concerns or fears, and we are building out models that will help us know at the earliest possible moment when we're starting to see upticks across the state in suicide ideation. We've awarded $5 million for peer support services in North Carolina. This, of course, builds on having used state funding to stand up this service, to create a pathway to a profession and a credential, and then working with our Medicaid partners to turn that into a Medicaid service definition that can finally sustain this as both the most important entryway that people can have to care, and also as an opportunity for employment and sustainment over their lives as they move through recovery. I am thrilled about peer services, and we will continue to double down here. For the first time ever, we had federal dollars where we could actually spend it on stuff and not just care and providers, and we used $4.4 million to fund 15 mobile mental health clinics and spaces across the state. I am particularly grateful to many of our LME MCO partners who, when called, said, yes, let's figure it out, and that has been super exciting. We know that increasing access to care has to be far more upstream, and that's why we've put $16 million in the last year into 20 health centers, treatment clinics, and community-based providers to expand evidence-based care. On top of that, $20 million for 5 CCBHCs across the state. This has been unprecedented levels of investment all at once, thinking cleverly about how we use every possible resource to meet the need. But I'm just getting started. $3.2 million for colleges and universities announced just recently to increase collegiate recovery, trying to get upstream to prevent substance use disorders from forming at one of the most important times and giving people in recovery a space to feel bolstered in that recovery where sometimes that can be a challenge. And what I'm particularly excited about is that after decades of having a healthcare system that has been financed separately between mental health and physical health, and we've started to merge them together in standard plans, we have been doubling down on integrated and collaborative care in primary care offices. I'm particularly grateful to our primary care partners who have made this possible. And when my team came to me and said, well, right now we pay about 50% of Medicare rates for collaborative care charge codes, and we want to increase it to 100%, I said, that's not good enough, 120%. We have got to double down on giving people access to care and catching signs of distress and expanding access for mental health services. Many of you over the last 45 years know that we saw massive closures of community health centers across the state. Some of the things I just spoke about are our effort to turn back that tide to increase access to care that needs to be there no matter what. But let me let you in on a secret if you did not know already, which is we have community health centers throughout this state, and they are called jails. 60% of people in incarcerated settings have substance use disorders or co-occurring mental health needs. It is a tragedy and a moral failure for that to happen, and we must invest resources at every step of the way to try to change that situation. That's why we've invested more than $15 million, thank you, $15 million for local diversion and reentry programs in 30 counties across the state. Bit by bit, working with sheriffs who tell us over and over again, we are never going to arrest ourselves out of this problem, who have the willingness to try harder, to do more, to make a difference in their jail. Supporting reentry initiatives for people to try to connect folks, because we know that here in North Carolina, based off research done here, that people who leave an incarcerated setting are 40% more likely to die of an opioid overdose than the general population. Connecting people to care before they leave and holding their hand into care as they leave is critical. And working with our partners at the prison and jails to increase that. And I am particularly excited about an initiative that we've been partnering with the North Carolina Council on Developmental Disabilities to support reentry initiatives for people with developmental disabilities. We've served over 150 people in just 2 years, and 87% of those individuals remain in the community without reoffending. That is life-changing for people, and ladies and gentlemen, that is life-changing to people's budgets in the federal government. Many of you, or I'm sorry, in the state government. Many of you know that I talk often about the wrong pocket problem. That when we make strides and wins on healthcare and behavioral healthcare in North Carolina, savings are found for local counties. They are found for social services. They are found for homeless services. They are found for any number of other things, not to mention pathways to recovery that are done well, lead to the opportunity for employment, for more taxpayers, to do reinvestments, not to mention it saves lives. I am very excited about one more aspect of our justice-involved population work, and that is just last month, well, now 2 months ago, we launched a detention-based capacity restoration program here in North Carolina. Capacity restoration is a service that has historically only been provided at our state psychiatric hospitals. And folks across the spectrum of need with incredibly complex needs to entry-level and low levels of acuity have been going to the most complex level of care at a price tag of $1,400 a day. They stay there twice as long as civil patients, and they hold up beds that could be used in better ways. Investing in detention-based capacity restoration and community-based capacity restoration for individuals that can be released on bond is an important increase of services that will help us, one, get people the care they need faster, embed so much needed psychiatric care in jails. Also, try to help people have access to a speedy trial, and most importantly, in this spectrum and in this room, freeing up much needed state psychiatric beds that if they are left full, it stops the entire system from working. I think we'll have some early data soon from this pilot. I'm incredibly excited about it. And let me tell you, we have approached 4 counties to do this. 1 said yes. Thank you, Mecklenburg County. And if you represent a county government in this room and you want to partner with me, I brought my checkbook. I think we all know how critical the care is needed for children in North Carolina, and that's why out of the gate this year, we released a coordinated action plan for kids. In particular, the children that we know that get squished between a woefully underfunded DSS system and a woefully underfunded mental health system, and they bear the weight. And they have borne the weight for far too long. And we brought together stakeholders from a diverse group of people at many levels, and we came up with this action plan, and we worked hard in the short session, and we have been able to get pieces of it funded, but we have got to do more. At the same time, we've been working with the Department of Public Instruction, and we released just a few months ago a unified school behavioral health action plan recognizing that mental health first aid and early identification, and guess what? Supporting teachers to help them serve the mental health needs of children is critical if we're going to make a turn not just in schools, but for future generations of North Carolina. As part of that, we took our North Carolina Psychiatric Access Line in partnership with many large, deeply blue institutions, and we expanded that line, which had historically been available to primary care practitioners as a way for them to pick up the phone and have help to understand what to do for the patient sitting in front of them that had a behavioral health need. And we said, let's expand that resources to teachers, and we have put it in 130 schools across North Carolina. So any staff or teacher can pick up the phone and have access to the insight that they need for dealing with the situation in front of them. And then I am also very particularly excited, recognizing the complex placement and in parallel with the investments that we've been making in community, that we still have a lot of folks, kids in particular, that are in DSS offices or in other spaces that simply cannot find a placement option. UNC Health had been thinking about how do they increase their levels of care and what they could do, and they set out on a path to think about how to invest in a child inpatient, high-quality psychiatric and specialized care for co-occurring and dual issues. How could they build a new facility to do that? And we thought it was going to take them about 4 years. We reached out to UNC Health. We identified a current facility that we're using in North Carolina that we could repurpose and take the folks that are using that facility and serve them very well in other places. And we've worked together and announced a partnership this last December. So instead of 4 years, RJ Blackley, which is in Butner, will be serving over 50 children starting in June. You know, the conversation about beds is one that we have been having for 45 years. And if you leave here and remember anything that I say, it's that I have great hair. But also, if you leave here and remember anything I say, listen closely. We have got to move beyond beds. I know that is the most proximate issue and at a time of crisis, but folks, this is a continuum. And if I don't do anything upstream, then we are always going to need more beds. We have got to be tripling down on our investments in community. We have got to be tripling down on our investments in recovery. Because guess what? There are a bunch of people in state psychiatric hospitals and other psychiatric spaces across the state right now that are medically ready for discharge but have nowhere to go. But I can't fix a problem unless I can track it. And many of you know that I have talked about this problem before, which is that given my 1 year of data, I get data once a year historically from psychiatric bed operators, and I can tell you that psychiatric inpatient beds, children and adults, are open 36% of the time. When at the same time, people say they cannot find beds. And so we have built beds after beds after beds after beds. I can also tell you that of all the beds that we have built and licensed, only 80% of them are operational. We took the COVID informatics system that we built in partnership with our health systems across the state, and we said, guess what? Instead of just sending us COVID data, this, that, and the other, I want you to also send us how many behavioral health holds you have every single day, so I can actually understand what has been a tyranny of the anecdote. And I'm here to report that it's right. As of January 24th, which is when I wrote these remarks, there were 350 people sitting in emergency departments looking for a bed. Now, how many of those people could be diverted into care with more intensive in-home resources? We've seen programs across the country in making a difference for those people. And how many of those people had we caught earlier with all the integrated care programs that we're trying to grow would have not ended up in that tragic and traumatic moment in the first place? But let me tell you this, just last week we launched another system, and we have got to come up with better names. This one, BH Scan, I think I'll call it the Woodard. And it tracks open beds every day and works with our inpatient psychiatric providers to say, guess how many beds we have? So, okay, I told you, 350 people looking for a bed, waiting really long periods of time, can't find one. How many beds do you think there was open at the end as of Friday? And I don't want to hear from Senator Bergen because I told him already. Over 100. Now, I'm getting ahead of myself, but I'll just say this and then I'll keep moving, which is if you've got a bed that's open and you have people that need a bed and they can't get into it, why? Maybe because that person doesn't have insurance. Maybe because the insurance they do have does not pay enough. Maybe because that person is in New Hanover County and their family does not want their child to be in a bed that is in Buncombe, understandably. But we cannot fix these problems. Well, first off, we can fix these problems, but we cannot do it unless we have more information. And so while right now not every single psychiatric hospital is participating in this system, I dearly hope they all do soon, because the spirit of fixing things will only work if we come together. So I've just laundered off a whole lot of things that we've done in the last year. And there's a lot more under the fold that has been happening constantly. And I want to take just a few seconds to talk about who I'm grateful for, which is that I am most importantly grateful for my team that works day in and day out in service to this state. At a time when we've come out of COVID, having run 1 million miles an hour, 14-hour days, 7 days a week, to try to do every single possible thing that we could for North Carolina, when we walked out of that, I looked at them and I said, okay, next up, mental health, we've got to go. And they kept running. We have a 28% vacancy rate at the department. It has doubled since COVID, and people are working harder than ever because they care passionately about serving this state. So please be kind to them. Sometimes you're not. Sometimes your contracts are delayed, and that's frustrating. And I'm excited for those contracts, but I didn't get any more contract staff. I'm also incredibly grateful to the members of the General Assembly and other elected leaders from across this state that have taken up this issue with such passion. And I am also grateful for all of you that keep focused on this, and I am grateful that this coming Thursday we will have our 6th mental health town hall that has been so exciting to bring people together in local communities to have these conversations, and I have got to give credit where credit is due, which is Senator Bergen, who pushed and pushed and pushed that we do this, and he has joined me at every single one, as has many other legislators, in bringing these topics to the forefront. I'm almost done with. So I'm almost done. Let me move quickly. While we have done much, I think we all know we have a lot more to do. And I want to scope out a little bit of what that looks like. I've talked about the fact that people are not finding beds in spite of having a bunch of beds. And I want to emphasize that fact. We have resources waiting in the wings. These beds that could be in place The game could be changed if we could invest in rates and if we could invest in parity and making sure that insurance companies, mine included, are covering things at an equal level. And that is really important to us. We also know we have much more to do because in any given week, dozens of children in foster care are living in emergency departments and child welfare offices. And among the children who struggle to find an appropriate placement, that have been referred to the department for additional help for coordination, a quarter of these children have been moved 50 times or more. And in spite, and it all comes back to this, in spite of investments that we have made that I have just talked about, North Carolina still has the lowest per child spending in child welfare among other states who have decentralized systems. And overall, we are 36th in the nation at the bottom of funding per child. You get what you pay for. 61 of our 100 counties in North Carolina have 0 children or adolescent psychiatrists. 61 of 100. Suicide is the 5th leading cause of death for North Carolinians between the age of 10 and 64. Last year in 2021, 2 years ago, I'm a little stuck, 10% of high school students attempted suicide. 22% seriously contemplated it. It's even worse in the LGBT population. 21% attempted suicide. 48% seriously contemplated it. As a young gay kid who went to Laney High School in New Hanover County, I can tell you that teachers saved my life. We are one of the top 5 states for population, but we are 44th in the nation for access to mental health. And while we work to integrate behavioral health into primary care, last week ECU Health announced the closure of 5 outpatient care facilities in rural eastern North Carolina because so many people were walking through the front door that didn't have a way to pay, they could not afford to keep it open. Rural health is going to bear the brunt of the worst parts of having as many uninsured as we do. And I will not say the name, but I will say that a behavioral health clinic reached out to me in hopes that we could save them because they are on the edge of closing and we have no resource that we could find. We worked really hard to do it. We have no resource that we could find. And so very soon, and I know staff have been informed, a behavioral health clinic in North Carolina is closing at a time when we know resources are needed more than ever. Bottom line, behavioral health is a business, and when people can't afford to pay for that service and they're walking through the front door, they cannot stay open. We will not have access and we will not have care without it. And this is why there is nothing, friends, nothing more important to save mental health in North Carolina and to really make a difference than expand Medicaid. $500 million a month, $8 billion a year, $3.7 billion for direct hospital payments alone. What does that do for outpatient clinics and expanding access to care and labor and delivery and getting upstream? What does that do for the fact that when people leave my psychiatric hospital on incredibly expensive antipsychotic drugs and they are uninsured, and they get switched to other meds because they are cheaper, because people are trying to get by, and then really tragic things happen? What does that do to the 100 and some people in my state psychiatric hospitals that I cannot discharge who have insurance to give them a path? What does that do for people that are leaving jails and prisons and they have insurance and they can stay out of the jail and break that cycle? What does that do for mothers who finally have health insurance to take care of their family? We know women make most of the choices for their kids. What does that do for child care, a critical service in this state that not only helps the early education of children, but also helps the long-term development and economic development of our state, and it helps child care businesses because they can't afford to give health care to their employees. There is not a better investment than Medicaid expansion, and I am tired of it not being done. And I am happy to say that I don't believe it is a matter of if, but when. And it is because of all of your hard work and leadership from the General Assembly in realizing that this opportunity for mental health is now. We sit at the cliff on the edge and we stare out into the abyss. Clinics closing, people can't find care, more than 100 people increasing in folks waiting in EDs, staff levels at record lows. Folks, it is only going to get worse. And I do not want to stand here next year and tell you how much worse it is. I want to sit here in front of you and say, here's all the extra things we were able to do because of Medicaid expansion. Here's all the extra things we were able to do because of the signing bonus of $1.5 billion we got from expansion. And here's all the things that we did together because we said, here are the things we need to do. Folks, this year is not the time where I need 1,000 flowers blooming. Everybody has great ideas, but we have got to focus on the most critical things. We have got to focus on increasing access through rates, through integrated care, through supporting kids in school. We have got to do big and bold and statewide things. We have got to focus on our justice-involved population. We have got to focus on where we know will make the biggest difference. We have so much resource waiting in the wings. Hundreds of licensed beds that are sitting dormant and unstaffed because they can't afford to operate them. We have so many talented providers that want to do more that can't afford to because we are paying them based off 2-year grants and they cannot expand on 2-year grants. Folks, we have got to make the meaningful investments, and so I ask you, let us work together on staying focused on the things that will matter most, because I promise you, if we put $100,000 here and $1 million there and we do a whole bunch and people feel good about it and we cut little ribbons, we will be in the same place that we have been in for 45 years. This is the time for bold action. This is the year for big stuff to get done, and I think we can do it. Thank you so much.
As I shook the Secretary's hand just a second ago, I told him he is freaking awesome, isn't he? Let's give him another round of applause. Secretary Kinsley, thank you for those great remarks. I think you just lined up the troops and we're ready to go follow you and get some of these things worked on. Max, come on up. I think we've got a presentation and I'll yield the podium for you.
Thank you, sir. All right. Thank you, Secretary Kinsley. That was amazing. I think it got us all ready to go fight the good fight. I just will move things along. I want to recognize the previous Paul Luebke Legislative Champion on Mental Health recipient, Senator Jim Bergen, for all the hard work that he did to receive the award last year, virtually. And this year, he will be presenting it to our new recipient, Senator Mike Woodard, but I will allow Jim to do that.
Well,
Thank you very much.
Giving it away now.
I know, I'm sorry about that. Thank you.
Thank you, Max. Max, I appreciate that, and it was such an honor to get that award last year, and I'm sorry we weren't all able to be together, but this is wonderful. It's a great turnout. It's good to see old friends and new friends, and I'm pleased to be presenting the 2023 Paul Luebke Award to a fellow legislator and able to hand that award directly to him. For the past 2 years, the presentations have been made through the magic of Zoom and video. The Representative Paul Luebke Legislative Champion Award on Mental Health is presented in honor and memory of, and achievements of the late Paul Luebke. Paul Luebke was a tireless advocate for improving and expanding mental health services in North Carolina. He worked with fellow members of the General Assembly and with community advocates to educate us on the critical need for comprehensive mental health services. This award recognizes members of the North Carolina General Assembly who exemplify Representative Luebke's dedication. Previous recipients are, and if you're here, stand up. I know maybe a couple of them are. Representative Ensko, Senator Behringer, Senator Tommy Tucker, Senator Floyd McKissick, Representative Josh Dobson. I know Representative Carla Cunningham is here. Please stand up. Thank you. And in 2023, we recognize Senator Mike Woodard for his service in the General Assembly, as well as his dedication to the broader community for over 30 years. Prior to his election in 2013 to the North Carolina General Assembly, he served for 7 years on the Durham City Council. His civic activities are extensive and include serving as a tutor at C.C. Spalding Elementary School. On the same day as a critical men's basketball game, I don't know, who's playing today? Do you all remember? I should mention, he is a Duke graduate and a loyal. I have to hear this. Last 2 years, he sat behind me, and I had to hear this all the time. He's a huge Duke fan, graduate, and his career includes serving as administrator with Duke University and Duke University Health System. I know that today, his wife, who is a lovely lady and a good friend of my wife, Reverend Sarah Woodard, is here with him. And those are the remarks that are written. And I want to just talk a minute about Mike, because Mike and I have gotten to be good friends. We met shortly after I was elected, and we just clicked. Now, we don't always agree on things, and we've had some great discussions. But I love his passion. I love his compassion. I love his interest. We serve on health care together. We've talked about numerous things together. He's gotten me in trouble a couple of times for talking to me during session, but I talked back, so that was fine. But Mike, I just want to tell you how much I admire, respect, appreciate you. We work on bills together, and I've said this before, and a lot of you've heard it, but a lot of the legislation that passes, nobody ever talks about, and you don't ever hear anything about it, because probably 95% of the legislation we work on goes through, and we work together on all those things. The things you see on TV are the things where there are some differences. But Mike is always very professional in how he discusses those. And Mike, I just want to tell you, I appreciate your friendship and your mentorship, and I am so proud to be giving you this award. Please join me. Okay, everybody stand up. Come on. I do want to add one thing, and if you've heard me speak, I usually use this quote. If your presence doesn't make an impact, your absence won't make a difference. Mike Woodard has made an impact.
Jim, thank you for those generous words. Those of you who know me know I'm rarely at a loss for words, and when I got the email from Linda Atack that the committee had chosen me to receive the Paul Luebke Award this year, I read the email, but I was kind of at a loss for words for a couple of reasons. One, sometimes, we deserve awards for some of the crappy work that we have to do as legislators because we work hard on some things. But for this one, this is love, and I love doing this work because it's so important. So to be recognized for that just means a lot and really did kind of take me back a little bit. It also took me back because it's such an honor to receive an award named for Paul Luebke, who was my neighbor for more than 30 years. Paul lived just a few blocks from where Sarah and I live. He was a friend, an advocate on so many issues. Sometimes we were warriors together on some issues. We ruffled a few feathers around Durham in our day. And then eventually he became my legislative colleague when I joined the General Assembly. And if you knew anything about Paul Luebke, you knew that he was passionate. And he shared that passion and wanted you to share it with him. And mental health was first, I think, among Paul's many passions. And he shared that with me, and quite honestly, it's one of the reasons that I care so much about this, was that Paul helped me to care more. It's an honor to share this award with the previous recipients of the Lubke Award, the incomparable Verla Insko, who has also been a North Star for me on this topic, my Durham colleague, Floyd McKissick, something in the water about Durham, we care about this. Commissioner Josh Dobson for his work in the legislature, my great friend Carla Cunningham, who continues to inspire me, and of course, my partner and great friend Jim Bergen as we work on these issues. So thank you very much for this honor. I accept it today not as a capstone, because I ain't going nowhere. In fact, I'm rolling up my sleeves, and I really accept this today as an incentive for us to continue to do our great work for behavioral health, mental health, for all the citizens of North Carolina. Thank you.
All right, Senator Woodard, thank you so much for receiving our award. And now it's time to get back to work, so there's no real time to rest. So come on back.
I told you it's back to work. So anyway. So the theme for our event today is addressing challenging transitions, why we need legislation and policy that effectively supports comprehensive community-based care. The remainder of our program is going to be divided into two pillars to reflect the lifespan from youth to our seniors. The format for each pillar is subject matter presentations, followed by a lived experience speaker, and then a panel discussion with question and answer, including members of the General Assembly and moderated by the great Rose Hoban. The participants for each pillar are listed on the printed program and the biographical information that's posted on the website and Facebook page. So let's start with our first pillar, early intervention and prevention. I'm going to invite our panelists, if they'll start making their way forward as I introduce them. Our panelists are Dr. Nora Daniels, adjunct professor at Duke University and the lead medical director for behavioral health and health equity at Blue Cross Blue Shield of North Carolina. Dr. Jonathan Copeland, Duke University Child and Adolescent Psychiatry Department. Cindy Ellers, Chief Operations Officer for Trillium Health Resources and a foster parent herself. Senator Sidney Batch from Wake County, District 17. Senator Greg Meyer from District 23, Orange, Caswell, and Person counties. And these two colleagues of mine have the great distinction of being social workers, the two social workers who serve in the General Assembly. Representative Marcia Morey from House District 30 in Durham County. And where's Rose? Rose Hoban, the great founder and editor of North Carolina Health News, will moderate our discussion as we begin. But we want to start our discussion, our remarks today with Dr. Dennis. Dr. Dennis, I will step aside and let you all begin. Go down the way, and Rose, we'll turn it over for your moderation at the right time. Dr. Dennis.
Thank you so much. Should I stay here or come over there to speak? Whatever I'd like to do? Okay, all right, I'll just stay here. So good afternoon, or good morning, everybody. It's nice to see you today. And I'm going to talk a little bit about early intervention and really thinking about it from a structural perspective. We're all aware that behavioral health problems are killing our youth and our children. And this isn't speaking in an exaggeration at all, and there's no getting around the truth that for children ages 10 to 14 in this country, suicide is the second leading cause of death after accidental injury, and suicide's third leading for ages 15 to 24 after accidental injury and homicide. And when we talk about accidental injury, number one is poisoning, and in this context, poisoning is code for overdose. right? So these are the behavioral health problems that are killing young people. And the fact of the matter is that being a 10 to 14-year-old in the United States is more deadly than it is in Bosnia, more deadly than it is in Chile, Canada, Estonia, or even Qatar. So these issues of childhood despair are being dealt with by other countries, and we can deal with them too. It's not unavoidable. We need solutions that are sufficiently bold to the scale of the crisis that we're dealing with right now. A tweak here or a nudge there isn't going to do a darn thing when you look at the scale of what we're facing. I think Secretary Kinsley spoke to some of these statistics, but in the Youth Risk Behavior Survey, we saw that 22% of North Carolina high school students had seriously considered suicide in the previous 12 months, and 18% had made a plan. And that those numbers masked inequities because 30% of students who identified as female and 48% of LGBTQ students had seriously considered suicide. And only 49% of students felt good about themselves. In 2011, that number was 80%. 33% feel alone in their life. In 2011, that was 19%. Things are getting worse. We can change these trends, and we must change them. And I say that as a psychiatrist, but I also say that, I think, almost most fervently as a mother of 3 young kids. My oldest is a teenager, a newly minted teenager. Our children need us as adults to create a world for them that is brimming with possibility, and a world where people take care of each other. They have to expect that. That's what I want them to believe. Early management of behavioral health disorders works. It prevents the progression of the disorders, it prevents mortality, it prevents morbidity. So why aren't we doing it? Why isn't it the norm? Last time I took my kids to see their pediatrician, who I love, who has been our family pediatrician for 13 years now, she told me there was a waiting list of 250 children to see the behavioral health providers at the highly esteemed health system where she works. Why do we allow this? Like, why? And what's happening to those children and their families while they wait? Do we not have an obligation to children to bring our most effective resources to bear to prevent their suffering? We have a fragmented system that makes it alarmingly difficult for children to access early care. And there's a widespread perception, I think, that behavioral health should be over there, right? Like, we'll send them over there. Well, they'll take care of it over there. Not our area of expertise. But at the point where we know this is the #1 cause of morbidity and mortality for children, I think it becomes everyone's collective priority. If you're providing health care, you should be providing behavioral health care. So why are we facing this? My diagnosis, looking at our system, is that we have a system where the behaviors that are undertaken are completely logical in a short-term profit-driven ideology, but make no sense over the long term. And this is particularly the case for children. Pediatrics and psychiatry both often are loss leaders. They're not profitable within the larger context of health systems. It's because of reimbursement rates. It's because a high proportion of children are on Medicaid relative to adults. And it is because taking really good care of children is time-consuming and complex. When you take care of a kid, you take care of a family, no matter what. And so we have to hold the needs of families and children central to the way that we plan services. When we make resources available as well, we need for health systems to take advantage of that. So Secretary Kinsley spoke to increasing the rate for collaborative care, the gold standard model for integrated care, increasing it to 120%. And Medicaid the rate is 120% of Medicare. At Blue Cross, our reimbursement rate is even higher than that for collaborative care. It's solid. There's a good business model. I thought I was going to get a no from our VP of network when I proposed that rate, and I got a yes. So this is a financially sustainable model, but we're still waiting for systems to adopt it and offer it so that we have really high quality integrated care in the primary care setting, which is really fundamental to early intervention, integration. And I have to say that I love my company, and also payers are not blameless in this scenario by any stretch of the imagination. For those of us who are trying to sort of manage health plans, when you decide on rates, often the rates, everyone's in lockstep, right? Like we're all like, oh, we have the same rate, it's a percentage of Medicare. We have to have creative funding and business models that are gonna make it work to provide high quality services early for kids. The incentives that we give to agencies also need to shift and change. When I started working for a large agency before I came to Blue Cross, the first time I went to our Charlotte clinic, there were people who were waiting so long, they were laying on the floor. I was like, what? This is a clinic? People were laying on the floor. Kids were waiting for multiple days to get access to services. And a big piece of that was that so much energy was being put towards that first assessment, but when we looked at the data, 50% of the people never came back for another visit. So what does that tell you? Is that care? I don't think that's care. Care, if we're looking for quality, we need to be looking at retention for evidence-based services at the third visit, not the first or the second visit. So I'm running out of time, but I want to just speak to a few things that we're doing at Blue Cross Blue Shield. So we have started a program called Blue Premier Behavioral Health Advanced, where we have a catchment area of 14 counties, and we have a population-based model that's really looking at taking a population of folks we know have extra need and providing them with care coordination, providing them with transitions of care, case management services, and paying on the basis of quality and shared savings for that population. We've got to get creative collectively if we're going to drive early intervention and evidence-based models, and our kids are worth it. Thank you.
I'll just move it over. Thank you, Dr. Dennis. My name's Nathan Copeland. I'm a child psychiatrist and was asked to talk about a few things. One that Dr. Dennis was already speaking to, early prevention, intervention, but also the landscape of pediatric mental health, many of which Secretary Kinsley touched base on, Dr. Dennis touched base on as well. As we know, and many of you here know, nearly 20% of all kids at any given time will be experiencing mental illness. But only about 20% of those kids will receive care. Additionally, of those kids that receive care, the average delay between onset of symptoms and intervention is about 8 to 10 years. 8 to 10 years without treatment. So what do we see from that? What we see is pediatric mental illness is the leading cause of kids dropping out of school, any form of disability of kids dropping out of school early on. 70% of youth in the state and juvenile justice systems have a diagnosed mental illness, many of whom are in the juvenile justice system because of an untreated and an unmanaged mental health condition. Suicide is the second leading cause of death, and suicide has lots of complicated aspects to it. It is the second leading cause of death from the ages of 10 to 24, and suicide accounts for more death than the next 7 medical causes combined in kids. During the pandemic, we saw the temperature rise across the board. We saw more kids with anxiety symptoms, more kids with depressive symptoms, more parents with depression and anxiety that are struggling to take care of their kids, more substance use disorders, more overdoses. It has gotten harder and more complicated for kids to receive care. However, one of the tragedies in all of this, and I think a lot of people have pointed this out, is we have treatments that work. We have interventions that work. We have medications that work. We just have to get them to the kid. We have to be able to identify the kid when symptoms are coming on, initiate treatment, and be sure we follow through that those treatments have been maximized and have been used to fidelity. And there are lots of people in the state that are doing this work. Fortunately, and we've heard many people are thinking about this. I'm a child psychiatrist with the team called the North Carolina Psychiatry Access Line that Secretary Kinsley spoke about. And what is the goal of NCPAL, and both the child psychiatry program and a perinatal program as well? The goal is to get mental health services to where that kid is, to move out of the mental health system and get them to the primary care clinic, get them to schools, right, where we serve as an access line for people to call about any questions that they may have, any providers, any schools, to reach out to us to ask, how do I manage this kid that has this behavioral health condition? And if we can teach that provider how to manage that kid that has that behavioral health condition, they can then do that for other kids. We also have a weekend training for pediatric providers to learn how to deliver evidence-based pediatric mental health care in the primary care setting. And we have trained hundreds of providers across the state of North Carolina who have now become that access point, that mental health access point for the kids in that community. There are other groups that are also doing great work. UNC, Atrium have started telemental health programs to schools, which is so exciting to see. How can we connect health systems to schools? Because we are all taking care of the same kids. And how can we support each other in that work? However, we need more. As everyone here has said, I was on the phone line this past week, on the NC PAL line, and received a call from a provider in a rural county in North Carolina who had an autistic kid that had significant behavioral health challenges. The family was burning out. The family didn't know if they could do it anymore. And I can talk about screenings, and I can talk about interventions, and medications could be helpful, and I genuinely hope many of those are going to be helpful. But that child is likely going to need some higher level of care, whether that's their own psychiatric provider, whether that is someone that can work with the family in the home setting. And so we need to figure out how to get those resources to families and kids where they are. We need to address the workforce shortage challenges, whether that's psychiatrists or school counselors or nurses or peer support specialists and everywhere in between. And how we do that across the state of North Carolina is critical. Parity has also been mentioned. How do we treat mental health conditions with the same vigor that we pay for and treat physical health conditions? This is something we have to figure out in the state of North Carolina. And lastly, how do we ensure that we support every kid in their community, no matter what they are going through or what challenges they are experiencing, so that prevention and intervention can happen in the community and the home? Thank you for your time. I appreciate you all. Sounds good.
No, you can't hear me? You can't? Yeah, there we go. First, let me say good morning. I'm glad you're here today for this important discussion. You showed up, and it matters. It matters a lot to people like me with lived experience. So my name is Cindy Ellers. I am a mom with lived experience in lots of diverse arenas. I have 6 children, 4 of which have complex medical and behavioral and IDD needs. I integrate that lived experience into my role at Trillium as a Chief Operations Officer, where I have served now as a public servant for the last 20-plus years. As a member of Trillium's executive team, in the C-suite, where the decisions are made, at least for this health plan. I have always integrated this lived experience that I have gained from my children in what and how Trillium implements things. And for those of you who work with Trillium, I think you would say it shows. Second, I want to talk about my lovely shoes. I don't have Secretary Kinsley's hair, or Senator Bergen, or Senator Woodard's hair. Clearly, mine's getting gray too, just like theirs. But I do have these shoes, all right? These shoes are a little different to wear to an event like this. They don't really match my outfit, I do know that. They are not at all fashionable. In fact, they're sort of ugly, blue, purple, and orange. I wore them for you Because if you remember nothing else about me, I want you to remember that these shoes walk a different walk than most people in our system, than almost all people in decision-making roles in a health plan. In fact, I'm pretty sure I might be a unicorn in that way, sitting at the C-suite level on the executive team of a health plan. Gives me a lot of ability to make change that's positive. The people that work with me know I bring the mom with Cindy to work every day when I bring the COO. Sometimes it presents challenges for them. You see, I'm very passionate, and some might even say extreme at times, with the emails I send and the things that I say. I do that for my own children every day of the week, and I do it for other people's children too, without difference. This walk in these shoes makes me push systems and people to do the right thing all the time, not just when it's easy, and certainly not just when it's something that they want to do. Lived experience is a walk that allows me to experience our system firsthand every day in the events of my life. It is not based on something someone wrote in a white paper. It isn't based on the representations or narratives constructed to fulfill an agenda. It is the experience of the systems in North Carolina from the outside in. This is a powerful experience to have every day. I also have the privilege in this role serving Eastern North Carolina to be a part of the team operationalizing how Trillium serves the community from the inside out. And it is informed by this lived experience. I want to say that when Max called me to agree to speak from this place of lived experience, it's not what I normally do. In fact, most of the time I'm more the COO in this type of venue. So I had to think about what I would say in my 7 minutes, because I could talk all day about this, honestly. Some of it you wouldn't want to hear, though. So I think it's important to talk a little bit about walking in these shoes as we go through some of the decisions that speakers before me have talked about already, and we'll talk about as the day goes on. Legislative decisions made by elected officials have to think about how the new law you pass helps or hurts all people. How the laws you pass help some people and hurt some people. These laws have to be intentional for all of the people in our state, and it is critical to understand that your obligation is to serve the people of North Carolina, and that is all of them, and Medicaid expansion would go a long way. For my friends and colleagues at the Department of Health and Human Services and the divisions that set the policy for behavioral health and IDD, the policy that you set really needs to be put up against that lived experience. Is it going to help or hurt people? Will it create unnecessary barriers that could, with just a little bit of vision, be removed? Or maybe adopt some interpretations that support people the way the spirit of the laws passed by the legislation were intended. Because sometimes the rules don't equal the laws in the way they get implemented. Oh Lord, she has given me the time. So, in my mind, every child, we're gonna sprint now, got on my running shoes, we're gonna go. You ready? In my mind, every child needs to be with the family. Everyone's goal has to be supporting all families for all children with the right services and right supports. All systems have to be accountable to this shared vision. It has to start with doing everything we can to support biological families to be successful and keep children at home. There is not enough service in the home today. After my son Caden became a part of our family through foster care and then later adoption at age 4, I lived a day-to-day life with a child that had experienced extreme trauma. The trauma I could see in every single aspect of his development, and have now. He is 20. I started looking into, back 17 years ago, I started looking into what could be done to have prevented this child of 4 years old from having experienced 5 different foster placements before his 4th birthday, until he found us and we found him. What if his family had gotten services and supports in the home? Maybe he would have not had to be surrendered for adoption. What if the 1st, 2nd, 3rd, 4th foster families had gotten supports? Maybe he wouldn't have been abused. Maybe he wouldn't have ever even had trauma. He already had the deck stacked against him because he had autism and was nonverbal and had a feeding tube and lots of other medical conditions. He didn't get the supports that he needed as a little boy. In fact, we were the adults that came along in his life and turned things around for him. We were the first people in his life that gave him a chance. I took those life experiences to work with me, and I shared them and set out to change things for kids in our area. Several of the providers in the room today are here about an evidence-based, that deliver an evidence-based model in rural eastern North Carolina called Child First. It is a model that helps families in the home. It's a home visiting model. It goes to them in their home. It's a licensed clinician and a coordinator that work with the families to get the services they need. Child First, Trillium invested $10 million of our own money to stand that service up. Child First children are 42% less likely to have aggressive and defiant behaviors, and Child First families were 39% less likely to be involved in child protective services, which has been sustained at 33% 3 years later. I'm almost done, I promise. Health plans like behavioral health IDD tailored plans have relationships with providers. I'm sure providers like Lou Ann Welsh in this room today can tell you that I have picked up the phone and called her and said, what does it take to get to yes for this kid to live in a family tonight? And Easter Seals and many other agencies have answered that call and delivered. We need more of that in kinship placement and professional parenting and lots of other services that we could add to this continuum. So it's not just about the beds, as Secretary Kinsley said. It's about the upstream impact to stop that from happening and not create one more Caden in this state. Thank you.
So hi, y'all. I don't know how we can follow that. Thank you, Cindy. We're going to be trading contact information. Anyway, so we're here to do now the question and answer portion of this panel. What they've described this as is that we have legislators and then we've got the experts to help them. So, and the legislators are all like, help, and the experts are like, oh yeah, we know what to do. So, I'm going to jump right in, and I wish we had more folks in the legislature here. I really do, because this morning has been incredibly inspiring. Listening to Cody was incredibly inspiring. I really hope that he's banging the table when he's talking to legislators, because that was sort of like, wow, okay. But that being said, I'm going to jump right in and ask some pointed questions, talking about seeing shocking rates of mental health issues, as Doctors Norman and Dennis talked about, Nathan and Dennis talked about. And so what legislative actions can be taken to help address these issues? I mean, what can legislators do? I'm asking.
Well, let's say the thing we need to do this week, which is we need to make it clear that we need to not pass Senate Bill 49 that would interrupt providing supportive services to LGBTQ kids who need access to support from wherever they can find it. And then let's move to what Secretary Kinsley said. Let's not take our eye off of the most important thing that we need to do, which is obviously Medicaid expansion. And I agree with him that we will get it done this year. It will take some work, and it will take much of the continued work that everybody in this room has been doing. And I think what I appreciate the most about what the vision that Secretary Kinsley laid out today is that when we've been in this fight for as long as some of us have, 25 years as a social worker and 9 as a legislator for me, sometimes we are so worn down by the day-to-day grind it out of what we do that we are just asking for that one small incremental gain of the thing that's in front of me. But we are still capable of doing big things in North Carolina. We can expand Medicaid, and we can do so many other big initiatives. Let's not forget about that. Let's keep the hope and keep on pushing for those.
So I would add, so I have an interesting perspective because I practice family law and I'm a child welfare law specialist and a social worker. So this is actually what I do every single day in and outside of the legislature. And I have on my caseload children that Cindy's described. She and I have worked together on a lot of these upstream issues. I have a child right now, dual diagnosis, who's 15 years old, who was sexually abused and has overdosed 3 times. And we're talking about placing him in Kentucky because we can't find a placement for him here. And that is with a family that has private insurance, right? So I think we need to have an honest conversation with a lot of our PHPs about the services that they're willing to provide here. We obviously need to address the Medicaid reimbursement rates, but we also have a lot of individuals out here who, in my law firm, for instance, my employees have a really great insurance plan. $1,000 out of pocket. It's great. We pay for it. But what we also have is a $50 copay for mental health. One of my employees, I tried to get it down, and the PHP said, oh, yeah, we can do that, but the only problem is you're going to have to go up on your deductible to get to a $25 copay, so then all of my employees would actually get worse health care. You can't have a system built on saying that you care about mental health but do nothing about those copays, because this parent that I employ has her 2 children in therapy and her. It's $150 a week. And y'all all know that you're going weekly for a while, right? Like, let's be honest. All of us need to be going weekly for a while. We should all be born with therapists. But through that process, you're not going to get to every other week, probably for 6 to 8 months. I don't care how good your therapist is, because we're all walking around broken people trying to heal our traumas, right? And bleeding on people that frankly didn't cut us. And so we need to figure out in this system how we actually legislate to ensure that our PHPs are doing what they need to for our private pays, and so that all of the Medicaid providers who used to see my kiddos on my caseload say, the paperwork is too much, right? The reimbursement rate is too low. And now we have concierge services for mental health providers when we need kids to be seen immediately, right? So what I would suggest is outside of Medicaid expansion, which will help with a lot of that, we also need to work with our pediatricians. We need to work with our schools. We need school-based mental health. Y'all, this is easy. We know where kids go, the pediatrician and school. I mean, and it's not rocket science. So why don't we actually work on a system where you identify families very early on with the risks? My pediatrician's office does not get reimbursed by the PHPs, but they actually have hired a coordinator who asks all the questions to every single family and then puts them in places where they can actually get the services. But as you already heard, 60 counties, don't have a psychiatrist? 61. So what are we going to do for all of those people who are living in counties that don't even have a psychiatrist, right? Who also don't have, I don't know, God forbid, internet. They can't do telehealth. So I will close this out and send it to my colleague over here. But what I would say is we also need like high-speed internet everywhere so that people can actually get access to the services. Sorry, my bad. It's my jam.
Yeah. Hey, I'm Marsha Morey from Durham. The first thing I would say, which doesn't intend to be political, we have to quit shrinking our revenues. We have, by 2030, decided to eliminate corporate taxes. We have the lowest corporate taxes in the South, 2.5%. What does that mean for us? We're losing $1 billion a year that could be put right into the needs we're talking about right here. We are shrinking what's available, and that is harming all of us. What it could be done while we're looking at, my passion is about kids in the juvenile justice system. What we could use some of that money to help fund services in-home. Kids need their families. What we could do to fund services in schools, so the first solution is not suspension, but it's working with the kids to get their educations. We have to change. I'll stop there with a clap. Yeah.
Cindy,
Smart
Cindy, go for it.
Yeah. So I want to talk a little bit about some school-based things that are a little unique to traditional school-based therapy. One of the things that Trillium has done in our 28 counties is work with our schools and our mobile crisis provider, Integrated Family Services, to develop this program called Crisis Chat. And it's on the login page when the kid goes to find out what their assignments are, what's going on at school, what the basketball game is tonight, where it is. The Crisis Chat is right there. And so our kids today, maybe not us, spend a lot of time on the internet, spend a lot of time in chat rooms, spend a lot of time doing that. So they click the link and it takes them straight to a chat. And on that chat, they're able to talk with the therapist on the mobile crisis team about everything from eating disorders to LGBTQ issues, things that may be hard to say in words but are easy to say in writing as an anonymous person. Now, they do have to put in some information, name, phone number, that, in case they're suicidal so we can get help to them. This crisis chat has been an amazing way to reach our children. You can do it on a smartphone, you can do it, and anybody can actually reach crisis chat, but we targeted it in our school systems. We did school-based therapy. We spent about $3 million launching school-based therapy in Eastern North Carolina. The number one challenge, and it goes to what Senator Batch is saying, has to do with if insurance has to be billed. So if it's not an insurance-blind model, if we're expecting people to pay co-pays, parents to consent, they have to then also consent that I can pay this copay. The provider has to be paneled with every insurance in the area, or there's children that aren't reimbursable. Providers can't eat that cost. These are all things that we learned, lessons learned, and man, there were many of them in trying to implement school-based therapy throughout Eastern North Carolina. We were able to do that in partnership with many of our providers. It has been very successful, but it had a lot of pains to learn all the lessons we had to learn. And so I'll stop there, but just want to say, you have to think about all of these details as you launch that. It would cost hundreds of millions of dollars to put insurance-blind therapists in every school. So we need really to leverage those insurance policies, including Medicaid and private pay, but we have to figure out a way to make that work for families.
I wanted to just speak specifically to the question of benefit design and just kind of alternative ways of looking at payment for behavioral health services, because we know that often when we provide these services that it actually lowers the total cost of care for children and for families, because let's say like a kid is doing better in terms of their behavioral health problems, and then suddenly the stomach issue that kept flaring up and causing them to go to the doctor, that's resolved because actually that was related to their anxiety. And as we've tried to implement some of these more alternative payment models that look more globally at trying to, you could essentially fund a provider and say okay, well, this person's just gonna get a bulk, pot of money to be available, essentially. And when we've tried to do that, there have been roadblocks that have come up. And so a little bit in the weeds, but one of them specifically in the ACA health plans, there's the Obamacare health plans that are brought in the marketplace. There's a rule that people have to be exposed to fair market value for whatever service they're receiving. And so that means even if I just wanted to give a capitated payment to a provider to see that person and say hey, there should be no cost share for this member under this program that I'm trying to create, that's actually not permitted under, and it's a IRS regulation. You can't do that. And so I think that like, it's in the weeds, but there are lots of things like that where you might want to create a program to make care accessible in a way that's much simpler and cleaner for people just who are just trying to live their life and get access to healthcare services. And then there are roadblocks that make it impossible to do that, which is, deeply frustrating.
Sure.
I'm going to piggyback on some of the previous comments that were said about schools as well. As a child psychiatrist, one of my best partners in the care of kids is teachers. And I routinely speak to teachers and occasionally school districts. And what I hear is that it is challenging right now. Systems are underfunded, teachers are resigning, people are burning out. And one of the things that I continue to think of that could greatly improve and continue to improve pediatric mental health is for our schools and our school systems to be fully funded and staffed. Happy, healthy, supported teachers lead to happy, healthy, supported students. And how we can support our schools is critical.
Yeah. You were reading my mind here, because, my next question here is, I took some moderator's prerogative by writing some of my own questions too. And, one of my oldest friends, someone I've known since the 80s, is a school counselor in Forsyth County. And we went for a hike a couple weeks ago, and she's told me that the past 2 years have been the hardest of her career. And that, as a matter of fact, she is planning on retiring at the end of the school year because she can no longer take it. She's so burned out. I mean, this is the woman who's the child whisperer, right? Her kids, who are my godchildren, always had extra place sets at the table because Kathy just gathered all the misfit kids, from the neighborhood. So one of the biggest issues that she talks about is how completely slammed they are. They're completely overscheduled, understaffed, and so I guess the question I have for legislators is, what kind of support can be given for school counselors and school psychologists to help them serve kids better?
Well, I'd start with, I don't know, social workers should actually get paid at the master's level if they've got a master's. Like, that's easy, right? I mean, when we are asking for people to make less than they could in private practice, right, then you're doing it, just like teachers, you're doing it out of act of love. No one is doing it to make money. Yeah. And so why are we not paying people, especially social workers, to go ahead and be in the schools where we need them the most, to identify the families and to help with services and to do the great work that they're capable of doing, but meanwhile they're working 2 jobs because they can't actually afford their own bills because they're too busy actually trying to just survive. And the ratios are horrible. I think it's like 4 times the amount of kids that social workers are supposed to be seeing. So what I'd suggest is you get more social workers and you actually just fund the positions.
I'd love to see us as well, like, think about what does prevention look like, even to the extent before a kid lands in the counselor's office or the social worker's office. Our children need cathartic experiences, which usually in schools come through some form of art, sports, or play. And you have to have time and people to give kids those experiences. I still work in schools when I'm not busy legislating. I was in a school this week that told me they've adopted a new program called Drop Everything and Play. And for 30 minutes a week, they stop and they just let kids play. Like, how novel of an idea. And I work with over 24 school districts all across the country, hundreds of schools, and they're the only school district I know that is actually emphasizing play right now. But when I first started as a social worker in schools, I worked in a program back in the heyday of the 90s where we actually did fund things like this as a primary initiatives. I ran a theater program for kids, and the whole idea was that you'd get them in the door through theater, and then as they started to unravel the stuff, they would actually come to me for counseling, but that it didn't have to be that there was a crisis before they walked into my doorway.
I want to just, again, moderator's prerogative. Cindy, have you folks ever, is that crisis chat, is that scalable? Could you scale that? And have you run the numbers on it and then presented it to a lawmaker? Just ask.
I think you're getting a little carried away, Rose, with your prerogative over there. So, interestingly enough, before I came here and talked about that today, I asked Natasha Hawley, the CEO of Integrated Family Services, if I could say that out here in this room in case somebody like you, Rose, asked that question. And she said, yeah, absolutely, it could be scaled. Absolutely, it could be scaled to the whole state. We've had it for a long time. Really, anybody can go on it. It's not restricted to 1 trillion people, for that matter. But the way that we're reimbursing it is a value add, right, to mobile crisis. Because if the child or person is in crisis, they also correspond with a response to the home. And many times that's in conjunction with other first responders. They have a whole system designed for that. But yes, the actual chat part of it could be connected. And when I think about what children need, children could be sitting in the classroom connecting with crisis chat through their phone or through the computer that's on the school's network. So it's on the school landing page. Now, this has been no small feat. And so when I think about what could legislators do, it's require every school in North Carolina to have something like that, right? Because we had to literally deal with every single school principal. It wasn't handled at the district level. No, it wasn't handled by DPI. This was something that we had to go to every principal and ask, could you please put this on Artesia Elementary School's webpage, right? So that the kids in your school have access to this. Because there's not just one place to go on that. Same with school-based therapy, by the way. It's every school principal's prerogative to or not allow you in the door the way things are structured. So maybe that's something the legislature could take up and help pave the way. One thing is funding it in the school, but we ask all the time for materials, for health education, for awareness, for things to be sent home with kids or sent out to kids, especially targeting the BHIDD population for access to care. No school in Eastern North Carolina will pass information from us to the students at all. And we cannot make them, but you could.
Okay. All right, glad I asked.
I said that as a mom, not as a Trillium employee.
So
I'm going to.
I just wanted to add one thing just with respect to schools, because I think that Greg's point about movement and kids actually getting enough exercise, and if I take off the health plan hat and just put on the psychiatrist hat, if we look at the things that are just foundationally necessary for mental health, it's the same things that are foundationally necessary for physical health, and schools shouldn't be an environment that are actually detrimental to the physical and mental health of children. Kids have to move. We have clear recommendation, an hour a day of exercise for kids. Kids have to sleep. If they don't sleep enough and they don't move enough and they're eating bad food, they're gonna be unhappy, and we just don't even have that foundation in place. And so how are we creating schools that actually just have the foundational needs of children at the center of the way that they create the curriculum? And I know we have to think about standardized tests, and we have to think about kids' performance and learning over the long haul, but we have data that shows that an extra hour of movement actually improves academic performance more so than an extra hour of study hall. So what are we doing?
So let me ask an easy question. One of the questions that came with registrations is, how does DHHS and the legislature plan to address the mental health workforce crisis, particularly as it pertains to direct care workers? And Cody talked about this, working outside of hospitals or in large integrated care settings with lower pay scales. Any thoughts?
So having been someone who is now paid student loans for 17 years for my education and just finished paying them off, what I would suggest, thank you, 17 years, y'all. 3 years early, I get an A+.
Feels good, feels good.
But what I would also say is that we're asking people to do yeoman's work at a ridiculously low rate as compared to what they can do, right? So psychiatrists, pediatricians, heck, they don't get paid the most. You're talking about how we pay for procedures in our healthcare system. We have to re-envision what we actually are going to prioritize. And so what I'd suggest, especially with regards to social workers, psychiatrists, et cetera, that if they go into an area that we need, that they have loan forgiveness. Right? We have a lot of amazing schools that are public schools in this state that the legislature funds. What we could also do is just say, if you go ahead, just like teaching fellows, if you serve in this area that doesn't have a psychiatrist, of which there's 61 wonderful places in the state of North Carolina you can go, then we will then, of course, forgive your loans after a certain period of time. I think that is a way that would be very helpful.
100% on board with Senator Batch on that. Here's one other one that I've experienced, and this is the second time today I'm breaking one of my cardinal rules, which is I was told early when I moved here 25 years ago that we don't care how you did it up north. But when I was in social work school in Chicago, the state had just settled a massive disability rights lawsuit, and part of the settlement was paying for anyone who had a BSW to get an MSW within 5 years.
Wow.
And all of a sudden, like in my social work classes, like they had to add whole new sections in order to have enough people who wanted to move up their credential and their professionalism. Wow. It is possible to be done to add hundreds of qualified professionals in a very short period of time.
That's fascinating.
I want to say something, Rose.
I don't think I could stop you if you.
So, you're a fast learner. So, I just have to say this on the direct support professional, the person that comes in the home and delivers the care, the staff who work on the innovations waiver or deliver those one-on-one services to members in Medicaid and state-funded service delivery. In 2014, that's a lot of years ago, right? Trillium set out with our providers to raise the wages to $15 an hour. It was voluntary. We didn't make anybody do it. Providers could come to us and say, here's what it will cost in the rates for us to pay our staff $15 an hour. That was in 2014. This is one of those examples of where lived experience on the C-suite informed it, because I lost my children's direct care staff to Target because the direct support providers in my area couldn't compete with Target or Walmart or McDonald's even. And so you saw that in 2014, it's only gotten worse. It's only gotten worse, right? And so today, Target's paying in New Bern, North Carolina, where I live, somewhere in the $20 mark.
Wow.
Per hour. Yeah, per hour, looking for a job. And so, let me just say, we have to do better by direct support professionals. Health plans in North Carolina that do Medicaid have rate-setting authority. Now, it's about having a will to and a want to. Some don't. We should hold them accountable, period.
So, I realized as I was looking through my questions, as folks were talking, I was like, so many of these things are about funding. And I know that lawmakers will always say that, there's a limited pot of money, et cetera. So let's talk about what you folks see that people in this room can do to help move the needle for lawmakers. What do people here need to know to do to help lawmakers see the light?
Well, don't lead with statistics. None of us are ever moved to donate to your favorite charity because they gave you a statistic, right? I mean, we're all learned individuals in here, and we all like to read all the things. And yes, we do care about evidence-based research, but a lot of our colleagues don't know what evidence-based research is, y'all. So I'm gonna need you to come to their building, right? The ones that are here know, but you see how many of us aren't here, right? So when you go, can you please go and talk to them and bring a constituent that actually can vote for them in their district? To hold them accountable and to speak from your heart, right? We have amazing stories. We have tragic stories. If you lead with that, instead of going in with statistics, I can guarantee you that you will have more legislators motivated to again, change legislation because they actually hear from people that they know and that they actually will see at the grocery store the next time they're there.
Anyone else have anything to add?
Well, I'm not going to pass up an opportunity.
Of course not. Of course not.
It takes a lot to get up in front of a room full of people and tell your story. It takes a lot to get up a room full of people like this and tell it in a way that it is meaningful for system change. It has taken me years to get to this level of ability to integrate what happens in my daily life with my job, right? And so one of the things that is really important as you bring people forward who have that lived experience that can tell that story that Senator Batch is talking about, it's helping them tell it in the way that it has the impact that they want, that they need. The other thing I would just advocate for is a seat at the table. And I am so privileged to have a seat at a table in this state, but having requirements for people who have that lived experience to have seats at the tables where those decisions are made is one of the most important things.
Can I just get a time check? Okay, all right. So I'm going to try and ask this fast and see if people can talk really fast. So initiatives like perinatal intensive outpatient treatment for at-risk groups and community crisis services and support are not covered by Medicaid and not available to all residents, right? So how can the state identify new and existing treatments and interventions and create access for those who are on Medicaid and/or people who are or underinsured? Any thoughts?
I mean, to me, that's a complicated question with a not complicated answer. Like, we have to fund innovative approaches that allow qualified people to do what they see and know is going to work.
Well, that answer was pretty short and, okay. Geez Louise. Finally, we've heard a lot about waiting lists and staff shortages. Is there anything, what can legislators do to improve this?
Money doesn't solve everything, but it solves a lot. Right? So, I mean, again, budgets are about priorities. We have to decide what we're actually going to prioritize. And if we care about the children in the state and we care about their mental health so that they can become well-functioning, wonderful, productive members of our society and our neighbors, then we need to figure out innovative ways. Much of that is going to be about money. That means we're going to have to look at really hard decisions about what else gets funded. But at the end of the day, that's where we are. A lot of this we cannot solve without money, right? And I hate to be that person to say it, but if anyone has a better and innovative idea, then by all means, let us know, because we would have already done it by now. So what I would suggest is that we actually have to have a really long, hard look at what we have in our system, especially with regards to early intervention for families, figure out what we can get for prevention, which is the most bang for our buck with the lowest dollar, and then see how that actually pays it forward throughout the rest of the time that a child, of course, is going to then become a part of our community as adults.
In other words, it means you have to run your ROI.
Yes.
Yeah.
And I'll add.
I would add to what Senator Batch said, priorities. I mean, follow what the General Assembly is doing. Follow what bills have gone to a committee. Is that the priority of the state? Is the priority of the state, don't say gay bill in the Education Committee? Is that really the priority of the state? Look at where we're focused. Are we focused on gun violence at all? No, not yet. But what is the concern of safety and mental health of our kids in schools, of our suicide rates? There are things that we should be doing and not these jokes of legislation that are culturally divisive and not addressing the needs that we're all talking about in here. Write your legislators. Tell them what your priorities are. Tell them to get focused on the ball. That's what we have to do.
Dr. Copeland, you had, and
Yeah, no, thank
quickly.
you. There's been a lot said about parity, about this concept of paying and treating mental health the same as we do physical health conditions. There is legislation about parity. We just have to enforce it.
Right.
And we have to have the mechanism to enforce parity across North Carolina. Health systems are very predictable. They will build things and create services if they know it's going to be sustainable and they can continue building into the future. And if we can continue to pay and treat mental health the same as we do physical health, we can see a lot of those services increase over time.
Great. And that's a great way to end. Thank you so much, everybody.
Breakfast is good, the fellowship is great, but the reason I love coming to this breakfast every year, year 17 for me, I think, are these panel discussions. Let's again thank our panelists. Looking for a water hose to hose down that second microphone over there too, so anyway. So it's time now for our second, do y'all want to take a minute stretch break? Y'all want to just stand up and stretch? Don't leave your seat though, all right? This is a one function break. You stretch and sit down, okay? All right, 15 seconds. We go here, so stretch. Shift your clothes around a little bit. Sit back down. Let me invite you to take your seat again. And I want to go ahead and invite the panelists for our second pillar discussion, if they'll start making their way to the stage while I introduce them. So our second pillar today is going to be discussing transitions and continuity of care. Our panelists include Dr. Samantha Meltzer-Brody, who's chair of the UNC Department of Psychiatry, Dr. Austin Hall, who is also with the UNC Department of Psychiatry and the STEP Clinic, Jonas Sharkey, a recovery educator, and our legislative panelists for this pillar include Jim Bergen, State Senator from District 12, Harnett, Lee, and Sampson counties, Carla Cunningham, representative from House District 106 in Mecklenburg County, Wayne Sasser, State House member of District 67, Cabarrus, Rowan, and Stanley counties. And again, our good friend Rose Hoban will be doing the question and answer session after our presentations. I didn't do a good job of introducing Rose earlier. Most of us know Rose. Read her every day, at least I do, and if you don't, you should. But Rose, as I mentioned, is the founder and editor of North Carolina Health News. She is a nurse by training. That was her first career, but after getting a master's in public health, she decided to become a journalist. So she brings both of those skill sets to her incredible work at North Carolina Health News. And I plug it all the time. It's bookmarked right at the top of my browser each morning. It's mandatory reading. If you work in healthcare at all, a practitioner or policymaker, you should read Health News, North Carolina Health News every day. So, Rose, thank you for that. Let's welcome this group of panelists. And Dr. Melcher-Brody, we'll start with you. I think you're going to come here, right?
Thank you. Well, good afternoon. It's actually the afternoon. And it's a great honor and pleasure to be here. So I've really been enjoying the conversation and discussions and wanted to share some things about what we're doing to partner with the state and with all the different community organizations to address what we are calling the behavioral health tsunami that we're facing. So I think that we've heard quite eloquently and passionately about the challenges that we face, and certainly at UNC in the School of Medicine and at UNC Health broadly, the impact of the behavioral health crisis weighs heavily on us, and it weighs heavily on us in all the ways it hits all the other healthcare systems, whether that's around emergency departments that are overflowing, demand for services with very long wait lists, the really heartbreaking stories of people calling for care. How do we get them in quickly? As chair of the department, I get the outreach when people are very frustrated because they're stuck in the ED, they can't get an inpatient bed, they can't get into other services. People are outraged, they're upset, and the problem for all of us is that there's so many of them. So we've been really working hard to advocate for mental health, for behavioral health, to address this crisis. And I want to share some of the things that we've been doing over the last year. We have focused in many ways on the mental health crisis in North Carolina's children. UNC Health brought in a national outside consultant to look at this problem broadly, to compare what we're doing in North Carolina with what's happening in other states, with the intention of really getting a sense of where we fall, what does it look like, what are their learnings from other places. And we came to the realization, and this is no news, there's no new news here, and we heard Secretary Kinsley talk about it, that there's an extreme lack of child and adolescent specialists, what we're calling CAP specialists in North Carolina, and as you heard Secretary Kinsley say, we have a real mismatch between one of the fastest growing population centers in the country and the lack of available services for our kids. We've heard about the suicides doubling in the last 10 years in our kids and the lack of mental health centers across the state. We need at least 400 more inpatient beds to support the demands of caring for child and adolescent psychiatry patients. We certainly need lots of community services too, but the reality is to meet the needs of an ever-growing population, given the prevalence where it is, we have far too few beds, and the average ED wait times are just unacceptable. So we are working on a complete overhaul and revamping of what we're doing with our behavioral health emergency department. And we need to have specialized resources. Ultimately, we need to have resources in the communities so you have early access and intervention that prevents people from coming in, as we've heard described. COVID has exacerbated all of this, and one of the things that has been really frustrating is there are not good models for the payers to cover intensive outpatient services in this population. So we've been in conversations with Nora Dennis and Blue Cross Blue Shield, and we're very hopeful. We will be rolling out an intensive outpatient program, starting with kids and adolescents, that can be expanded, covered by Blue Cross and Blue Shield. I simply can't do this without there being appropriate reimbursement. And so one of the challenges I face as a department chair of a large department at a public institution as part of a large healthcare system is I can't advocate for change without making a business model to my boss. And healthcare systems, as we've heard said, will not invest in things, and Dr. Copeland said this, if they just see it as a giant loss that cannot be sustained over time. So all of this requires partnership to address. And I think that, Where we stand today is just grossly unacceptable. We've been hearing it said all morning. We're ranked 42 in overall child and adolescent psychiatric care, 46 in total youth that are, really just huge numbers suffering with major depressive episodes, and it's time to do something different. The why of what to do something different is not just about taking care of our kids, which you would think that in and of itself would move people. But it's also because North Carolina cannot continue to thrive and be a state that's sought after by top-ranked businesses to come in if we don't have a mentally well population. So if other states in the country invest in their youth and invest in their mental health, and we don't, we will end up with a sick group of people, an unwell population that won't be able to respond to the demands for employers to come in, and they will no longer be interested in coming here. This has huge impact economically, affects recruitment and retention. So investing in the next generation, I think, is just makes good sense, but it makes good economic sense. So I want to share what UNC's vision is to do this. So these are goals we've been working with, that we've been talking to state legislators. I've had a chance to talk with some of our folks here that we're continuing to move forward on. Our interest is, how do we expand services to all 100 counties in North Carolina, that we educate the next generation of providers, of mental health clinicians broadly. There's not enough of us. We need more. That means that universities and training programs need to be able to expand and invest in that. We need cutting-edge clinical programs that can be deployed broadly, and we need new research and discovery that actually allows us to have new treatments that change the trajectory. All of this requires public-private partnerships. It's not something any one healthcare system can do. It's not something any one program can do. It requires us working together. These are big societal problems that require partnership with government, require with industry, with payers, with public institutions, with academia, with community-based services, all of it. And here's the rubric we're looking at. You start with prevention in the outer blue circle. If we think of 5 areas of the care continuum, you work on efforts to prevent things from happening in the first place. How you then scale up adequate outpatient care, how you then roll out intensive outpatient care. This is all meant to keep people out of emergency rooms, out of being in crisis, out of needing hospitalization. And then how do you have adequate crisis services when that bar is exceeded, and how you have appropriate inpatient beds. But I think we have to think about broad-based care continuum. That's what we're looking at. And we are extremely honored to be able to partner with North Carolina DHHS on opening this new UNC Hospital's Youth Behavioral Health, the new YBH, that's the official name that we're calling it, in Butner, North Carolina later this summer. We have hired about 6 child-adolescent new psychiatrists that are coming to work here, and more are coming, as well as social workers, psychologists, and the other rest of the team. There'll be 4 units, 54 beds. We want it to be really superb, cutting-edge treatment. But we do know this. We have to address the social determinants of health and mental health. We have to work with our population writ large in the state, in all 100 counties, to figure out what are the needs. The needs of our different constituents vary greatly. Everyone, is not in the same situation. How do we address the issues that impact specific groups to be at higher risk and have specific targeted interventions that change trajectories? And together, I'm very hopeful we can make a change. So I'm been in North Carolina now going on 27 years, and certainly see it as my home. And I think that this state has always done great things and risen to great challenges. And this great challenge we face, I'm confident all of us working together, we can move the bar in a powerful way for the people we serve. Thank you.
I just thought there was. Okay. Yeah, I'm. Oh, go for it.
Oh, no.
Go
There
for
we
it.
go.
Go for
Well
it.
done. No, please.
Okay. All right.
We figured it out, yeah.
I'm Austin Hall. and I have the pleasure to work in Samantha's department. Thank you so much to the program committee for the invitation to take part in this important event. I was thinking about the theme of this pillar, transitions and continuity of care. I really struggled to narrow my focus for this brief talk. So many potential worthy topics. Ultimately, you're going to hear me drill down to some themes we've already been talking about, but I'm not going to regret that because they're so important that we should double down on them here. I thought about a transition of care I had last year myself. I was looking for a new primary care physician. My physician had retired, and I asked all my colleagues at UNC for names of great potential physicians. I have that advantage working at UNC that I've got lots of colleagues I can query about who I should see. I ultimately chose someone who was just a few weeks out of her residency, but I'd heard she was just a stellar resident. And I showed up for my first visit, and she said, "Why did you choose me? Why did you choose someone with so much less experience than a lot of the other providers you could have chosen in our system?" And I said something like, I'm just here for a routine checkup today. I'm really fortunate today that I don't have an acute issue for you. I'm here because I just turned 50. I'm here to get to know you. I'm here because I've heard great things about you, and I'm going to need you in 5, 10, 20 years. I'm going to need to develop that rapport with you now, that trust in you now, so that I can really lean on that when I have major health challenges down the road, when I have major health decisions and I need a partner in that decision-making process. I'm here because I need you on my team for the long term. Our individuals with serious mental illness in this state never get that, though. They never get somebody who stays on their team for the long term. Isn't that what we would all want in a care provider? The individuals in our system who would benefit the most from stable care team relationships hardly ever can find them. And one reason is we have so much turnover in the mental health workforce. We've got to reduce that turnover. We've got to better support our mental health workforce. We could design the best array of services in this US, but if we don't have the workforce to deliver them, we're never going to see the benefits of those services. We've heard a lot of national media coverage in recent years about physician burnout and nursing burnout. But the crisis in mental health workforce burnout is just as acute. We can't afford to lose social workers who want to work in community mental health. We can't afford to lose peer support specialists. We can't afford to lose any of the professionals who want to be committed to this work. We can't replace them. Never in my time in community mental health has it been so challenging to find talented people who are willing to do this work. We can't replace the people. We can't replace the relationships, the trust that individuals with mental illness establish with the boots on the ground professionals who do the day-to-day work. How many times can we expect individuals to share their stories, their goals, their fears, their histories of trauma with professionals who soon depart their team, leaving those individuals to have to start the process all over again and again with someone new? So how do we do it? How can we better support our mental health workforce? Of course, we have to compensate the workforce in a way that reflects the demands of this incredibly emotionally exhausting work. Our network needs funding that's predictable and rational and reflects the increased cost of doing business in the current climate. Certainly, I have to mention Medicaid expansion here as having the potential to be a game changer for funding stability for our provider network and therefore our mental health workforce. I also think we need to be really thoughtful about assuring that those in the mental health workforce have every opportunity to maintain personal fulfillment and a sense of accomplishment from the work. We can look to some work being done around physician burnout. As a model, there have been changes put in place in recent years to try to reduce the burden of documentation and other administrative tasks for physicians. For the mental health workforce in North Carolina, we need similar thinking. We need to support them in spending less time at the computer, more time with clients, more time in their communities. Let's offer robust training opportunities, but then let's trust them to do the work. Let's be less prescriptive about all the bullet points that need to be covered in assessments and reassessments. Let's allow time and space for unstructured, natural conversations that allow professionals to really get to know the individuals that they're working with. Train and then trust. We need to enhance the sense of autonomy in our mental health workforce so they can feel able to use the full scope of their skills, so they can feel that what's driving how they spend their day are the needs and goals of the individuals they serve, not the need to check boxes to fulfill administrative burdens associated with the services. In closing, I'm going to end on a hopeful note. I have the privilege of working with psychiatry trainees, and I get to see that the field of psychiatry is attracting top medical school graduates like never before, and that so many of those graduates are entering the profession with a very deep interest in the health of vulnerable and underserved populations. And I suspect that our schools of social work and nursing and other disciplines are also seeing the same thing. We're going to need all these graduates, then we're going to need a lot more of them. The workforce need is immense. We've got to invest in expanding training opportunities for all types of clinicians. We've got to identify more individuals with lived experience who can bring their strengths to the workforce. But we'll never catch up to the workforce need if we can't create the conditions for our mental health workforce that allow them to maintain their commitment and find joy in what they do. Thanks to all of you in the room who continue to commit to the long haul of doing this vital work. Thanks.
Okay, I'm going to cross the stage again, this time to actually give my presentation. I promise I'm not playing Candy Crush. I am bringing up my remarks. Before I begin, though RI International is my work family, I'm here today simply as Jonah, a person in recovery from chronic pain, major depressive disorder, and substance use disorder. I'm a person who has been labeled with severe mental illness. I've been hospitalized multiple times, and at the end of my last crisis experience, was thought to be a person without a path back to the life I had before chronic pain, addiction, depression, and drug-induced psychosis destroyed all that I had built in 15 years of previous sobriety. Without the advocacy that I have engaged in myself and the support of my family, my friends, 12-step groups, and eventually Social Security disability, I simply wouldn't be here today. I strongly doubt that I would be alive. It was actually thought when I finally was able to get Social Security disability that I was really going to be relegated to the couch on maximum doses of medication for the rest of my life. And as a peer support specialist, and now as an instructional designer, I've seen countless other individuals who have been relegated to that same place, often in group homes, often in day programs, where their potential and continuity of care has stalled. We talk about this as the fuel tank. We have to keep refilling that fuel tank so that recovery does not stall, and it happens all too often. So for me, continuity of care looked like this. I say that I was hospitalized multiple times because I was put on a 72-hour hold. I survived that 72-hour hold. I was put into a 30-day intensive outpatient program where I filled out a calendar every morning and sat in process groups with people that were just being stabilized on the max doses of medication. I understand that that can be effective, But for me, what it meant was as soon as I was done with that 30 days, I didn't know what to do next. And I didn't know how to ask for it. And I returned to a family so stunned by the trauma of what they had just endured in my life that we didn't know what to do but to go back to what we knew. And so a year later, I'm in the hospital again, and the same result. And a year later, I'm in the hospital again. But this time something changed, although it took what we call in 12-step rooms as a bottom. I ended up homeless. I ended up having to resort to petty crime to survive while waiting for my third appeal for Social Security disability. For me to ask for help from my family and to say, I'm done. Like, I'm not going to survive this time. And I'm so grateful for those people on that last slide that I had those people. So many people don't have those people. I grieve for so many of the people that I serve. As much as I want to be that person for them, that's ethically not my role. I'm limited in what I can do there, right? But the gift was, I landed in Michigan in Ingham County and was referred to community mental health. And what they do there is you get weekly counseling, you get a psychiatrist with medication management, and you get a DBT group, dialectical behavioral therapy. And over that time, I stabilized. I stabilized on more correct doses of medication because I had a provider that got to know me. And I got actual therapeutic skills that I could apply to my recovery. But again, if not for the next step, my recovery engine would have stalled again. But my folks found out about Charterhouse. Now, Charterhouse follows the same clubhouse model that people may know from Threshold and Nova. That's right. I love the clubhouse. And they provided something that I feel every person needs for stability and thriving in recovery, which is that sense of meaning and purpose. Every day I went in and I did my attendance on the little database. I helped work on the newsletter, and I started out an hour a week, and after a few months I was there like half a day every day. And that's what brought me back to life. Oh my goodness, a minute and 30 seconds. No, I can't skip that. So when I came down here to Durham, I joined Wellness City. I was told in the 12-step groups about peer support and that somebody thought I could be a peer support provider. But I was so flat. The amount of medications, mood stabilizers that were actually inappropriate to my care, that's not a soapbox, that's just my experience, brought me to Wellness City where these lovely people saw in me something different, and they trained me as a peer supporter to look for that in people. What's behind this? What's behind this flat affect? What's behind this person that desperately wants a job, but they can't get to their job because their group home won't take them, because Access takes an hour to get them there, and they get fired because they show up late, because their guardian can't do what they need to do because they have 50 people on their caseload, and they can't sign off on releases to be able to do what they need to do. So those are the things that I'm really urging us to think about. I'm really gifted, I'm really privileged, I'm really blessed that I have been able to keep this engine of recovery going. I finished my bachelor's degree, I finished my master's degree. I'm now, well, thank you. And it was a lot of hard work. I'm wrapping up, I promise. But what I'm doing with that is I've moved beyond one-on-one peer support to training peer supporters in this crisis continuum. Because as peer supporters, we have a unique skill set to meet people on a warm line, to meet people in the community before they even need a warm line, but to catch them at mobile crisis, to catch them at the crisis center, to make sure that they understand that they don't have to sit on the couch for the rest of their life, they can be who they are meant to be. And so I'm just going to leave this up here. This is Maya Angelou, and we all know. But develop enough courage so that you can stand up for yourself and then stand up for someone else. Thank you.
So, thank you for all of that. So we're going to jump right into questions again. And so I didn't ask it during the last round, because I'm going to ask it now, because Senator Bergen, you have said that you expect Medicaid expansion to take place this year. Can you confirm that, was the question. But I think, you know, but what can people do to help move the needle on that?
Thank you, and again, it's a pleasure to be here, and thank you all for being up here to cover for us. I was asked out in the hall earlier about that, and I said, yes, I think it will expand. They said, well, what percent? And I said 90%, and I'll clarify that a little bit. And people always say, why didn't you do it? Why haven't the Republicans, why haven't we already done it? And a lot of it had to do to get to a place where we could do it. And a lot of you know we were a year and a half into having the PHPs running. We've done away with that wide jump up and down of $200+ million. And so now we are in a place where we can do it. Plus the longevity of affordable health, and a lot of you know I'm in the insurance business. I've been for 33 years now, and sell health insurance and worked with all the health plans in the state over the years. And it's time to do it. There's so many needs. There's so many opportunities. I've been going over the list of how much the hospitals will get from HASP over the last couple of weeks, and we're talking about over $3 billion a year. And we've got hospitals that desperately need that money, especially in rural North Carolina. And the Secretary and I have been traveling all over the state. We're going to be in Greenville this Thursday, or in Pitt County. I think we're going to be in Greenville we'll get that address out. But there's just so many opportunities to do things. And as I've been passionate about mental health and doing all the things about mental health, I think that it's the right time. We passed it in the Senate. We passed it 44-2, so that shows our conviction on it. Now, people say, yeah, but you put things in it like CON. But let me explain. I served on, I'm one of the few legislators that served on the SHIC. And so they developed the state health plan, and I was appointed and served on that for a number of years. And so I saw what happens when someone comes and does and applies for a CON. It's a multi-year process, usually at least 2 years, cost a minimum of about $500,000. I was involved when I was on the hospital board that went over about 3 years and cost both parties about $9 million. That was money that was not spent on health care. And so I say this a lot, I'm a business guy. I don't spend money, I invest money. I see mental health and health care as a great investment for the state of North Carolina. And I think that's where we're at now. So I've talked to my colleagues about it. We intend to do it. One of the things that you might not know is the new 54-bed adolescent mental hospital at Butner actually will require a CON to open right now the way it's written. We're trying to figure that out, and I've got legislation if we need to do it to introduce it so we don't have to go through that. But those are the kinds of things that we need to be more practical about in how we approach it, how we figure out how to do health care and do it quickly. And I can make a decision in one of my companies and implement it today. In the government and in the state, it takes, I hear my friends here, Cindy's laughing about this because she and I have talked a lot about foster care, and sometime we'll all talk about foster care too. That's something I'm passionate about too. But yeah, we're going to do it. We just got to figure out those nuances, the whole scope of practice, the CON, the other things that are in there, and I think we can do it. We're working on it really hard right now.
I might put the representatives in the room a little bit on the spot, because it sounds like the Senate has made their decision. What's it going to take to move the needle in the House?
Okay, right now, I'm going to take a moment for a personal privilege and kind of move away from what you're talking about, because we have moved into Black History Month, and we haven't acknowledged it here this morning. So I have to do that because I am humbled to serve with all of my colleagues. I'm the longest serving nurse in the North Carolina State House, and I've served over 35 years in the healthcare field in multiple fields. But we have to talk about, you're saying transitioning, but where are we going? And one of the issues that is very close to my heart, besides the mental health and the foster care, is health equity. Health equity, as well as, and we watched the TV all this past week and saw Tyree Nichols killed. So trauma is in my community. I'm traumatized, okay? But when it comes to health equity and people that look like me, people of color that need services, we the last ones to get them. Let me explain to you. I've been involved since my son was 14 years old. My son is 44 years old now. I've told my story here. But if it had not been for my nursing background and also understanding the aspect of government entities and how to connect to those people that can help me move in the right ways to get the services that we needed, I wouldn't be here. So it's an aspect of transitioning. Where are we going? Are we ready for cultural humility? Where everybody is the same and everybody is able to get the same services. I got to tell the truth. That's what I came to do, and that's the space that I have to be in. We got 16,000 children on the innovations wait list in the state of North Carolina, 16,000, and that number went up. But if you go back and dissect it and look specifically at the people of color that are on that wait list, you're going to see a story. But we've got to open our eyes. We've got to be receptive. We've got to be ready to move in a stage of cultural competency, cultural humility, and start really focusing in on health equity, which now we want to say they are social determinants of health, right or wrong. We got to call it what we want to call it in order to move the dial. So I think we have a ways to go. We behind. Cultural competency has been around since 2003 when legislation was first done at congressional level. This is 2023, and we still haven't implemented all of the cultural competency inside of our nursing education or physician education, or even in law enforcement. We have got to move where the demographics are moving, and we're not ready yet. So we got to get ready. Everybody got to get ready to go, or you're going to be left behind. And it's not just going to take dollars. It's going to take some creativity. It's going to take some innovation, and it's going to take a lot of readiness on our part in this room.
So Representative Cunningham,
Yeah.
so to bring what you're saying back to the sort of this panel, you talked about being able to advocate for yourself. Like how, again, asking, what can people here do to advocate for themselves, to advocate for Medicaid expansion with your colleagues?
I'm going to tell you, the first time I met the big Senator Berger, I actually came up to Raleigh with a group of IDD from Lifespan. And I was supposed to meet with Senator Tillis at the time, who was the Speaker of the House. And he couldn't meet, so Senator Berger graciously met us, and I actually took a family in. And I was shocked of how engaged he was when they told their story. And he took the time, and he didn't interrupt them. And I was like, he really listened to them. And it made an impact. But now, I sat down next to him at the nursing convention last year, and he didn't remember me. But he remembered that I brought the people in from Lifespan, and they told their story. So I think when you can find that commonality, and don't look at us like, that's just a title. We're just as human as you are. Just as human as you are. I have my own stuff, you got your own stuff. They got their own stuff too. You might not can't see it, but they got their own stuff. So when you come in, tell your story. And sometimes I know it's difficult to tell your story. But tell your story and find that commonality. Sometimes look into their background. Look and see if they have a disabled child. Look and see if they have an autistic child. Look and see what their family looks like, because who are they going to love? It's their families. And they're going to find it in their heart, that softness for the ones closest to them. So when you bring your issue, it's a commonality.
You have anything to add, Representative Sasser?
Briefly, which is one of my favorite terms, would like to just thank everybody for the opportunity to be here. I want to second everything that Secretary Kinsley said in his speech, and then I can probably just shut up and it'll be fine. But no, when, and I said when, not if, when we pass Medicaid expansion, then that's going to solve a lot of problems that the other panel has already talked about, because it's going to provide funding. We're already having meetings talking about when we pass Medicaid. I'm going to go out on a limb with my friend Senator Bergen and say probably March. When we pass Medicaid, then how are we going to take? Oh, I know the time's ticking.
Setting my watch by it.
But I mean, we're having meetings now, 2 or 3 a week, talking about when we pass Medicaid, and that $1.5 million that comes to the. I got in trouble in a hospital meeting and called it a bribe. It is a bribe, but it's a very effective bribe. Okay, I mean that it motivates me when we have a $1.5 billion to spend on what the state wants to spend it on, and we want to spend $1 billion of that on mental health. So that's all I got to say.
I look forward to writing about that. So recognizing that, primary care physicians are a current priority for the state in supporting everyone's health care, along with mental health care, psychiatric and therapeutic services are still critically needed. So low reimbursement rates from Medicaid, pre and post expansion, and to private behavioral health insurers contribute to a lack of availability to services. So, is there a plan to address this in the plans for Medicaid? I see you moving, Representative Sasser. Go for it.
As far as the providers, and let me just run through, and I don't get in a lot. I won't get into a lot of numbers with you, but let me just remind people where we are. We've got somewhere right now between 2.7 and 2.9 million people already on Medicaid. Now, and Cody and I go back on numbers all the time, but there's about, according to the department and the governor, there's about 600,000 that would go on Medicaid. We currently have somewhere between, the department says about 300,000 that would come off if we ran redetermination right now. Those are people that have been on, and we can't take them off until starting in April. We can start through the process. And but the numbers are skewed a little higher than that, and I've been meeting with Equifax and all the companies that we're going to end up with about 3.3 to 3.4 million people on Medicaid. That is 1/3 of the North Carolina population. and I say this many places, that is not long-term sustainable. So we have been talking, I've been on the calls 3 different times with the White House. Secretary's been up there visiting, and he and I have been working on talking about this, and I've been proposing an idea where we use Medicaid dollars to pay for people on Medicaid to go to community college. We provide child care for them while they're there in community college, and then we put them into a job because we desperately need workers right now. If we did all of that, because I believe, and I'm a person of faith, and I'll get into the mind, body, spirit in a minute, because I think those three are critical to be dealt with together. But if we did that, we would have people that would not be trapped in a life of living on a government program. And I don't think that was ever the intent of Medicaid or any government program, was to entrap people to where they stayed there. Right now, we have in excess of 530,000 people that have been on Medicaid for more than 10 years. And folks, it's just not good for them. I think God designed us to be self-reliant, self-sufficient, and we feel so much better about ourselves, especially men, if they can take care of themselves and their families. So this is just real important to me, that we give people those opportunities. So that's what we're working on right now, and that's what we're trying to get folks to. So, and I'd like to have been on the first panel too, because I think a lot of problems can be solved if we start early. And I've talked to some of you about my 4 threes, and we're going to be looking at doula services. We're going to be looking at more midwife services. I think the earlier we get engaged in helping people from the time of conception and following children all the way to 3rd grade to make sure they're great readers, we're going to set ourselves up for success long term. Now, lastly, I was in Yadkin County this past Monday. We went up to look at early childhood. They have no 4 or 5-star child care centers in Yadkin County. Wow. So the 3 largest employers met with us, and we met with a whole group of local officials and everyone to talk about providing child care so people can go back to work. And the largest employer, Unifive, they employ about 1,200 people, and they said when COVID hit, the majority of their female workers had to go home because somebody had to be there to take care of those kids, because they didn't have child care providers, they didn't have all of those services, so they took all of that out. Now, this company runs 3 shifts, 7 days a week, even right now. They desperately need workers. They don't have child care. And so you see this problem, and us being a very attractive state for people to do business and us bringing new businesses in, it's going to get even more complicated. VinFast and Wolfspeed are coming to Chatham County. I don't represent Chatham County, I represent Lee County right beside it, but I'm still on the board of directors of Central Carolina Community College, and I'm finance chair. And we've been having meetings because we're going to have to come up with 17,500 workers to staff those businesses. Folks, we don't have them, and we don't have the facilities right now. We're partnering with 3 other community colleges to try to make sure that we can train those folks. So if you're looking for a job, go to Chatham County, because they're going to have tons of jobs, and they're going to be good paying jobs, and we're going to try to have folks there to train people for them. But as the secretary and I, when we go around and talk, we talk about this is a big puzzle. There's a lot of pieces on it, and all of you all are a piece in this puzzle. All the providers, all of the folks that are working in all of it, all of our fine folks here, and just one more thing before she turns the red light on me. She's been really nice. I sat with her and watched her float the switches. You did really good. But I was at Atrium, the secretary and I were at Atrium 2 weeks ago, and we were visiting their facility. It was completely full. The kids, the adolescent ED down there was completely full. They put a kid on a plane that day to go to Utah for services. Right now, if you add the folks in our juvenile justice area and the folks in our LME MCO area, we have somewhere around 600 kids out of state right now. Folks, that is not acceptable. And one of my goals before I ever leave the Senate is I want us to never take someone to an ED that has a behavioral or mental health issue, unless they are medically injured. I never want somebody to have to go there, and I don't want any of our folks to have to go out of state. We are the 9th most populous state. We're first in a lot of things. We need to be first in health care. We need to be first in mental health care, and especially for our children. So that's my passion, and I thank you for not turning the light on.
I'd just like to provide a quick anecdotal backup for a point that you made, in that part of being left on the couch was part of Social Security disability. I fought so hard to get those benefits, but it limited me in some ways that I hit a limit on what I could do without losing that protection. And another reason that I'm an advocate for peer support is that it provides a place for somebody to really test their capability and their ability to see if that's possible. So my transition off of Social Security disability this past year, as I transitioned to full-time, was very scary, and at the same time is a huge gift. And it just really makes me feel strongly, again, about those people that are in group homes that are living on $60 a month for themselves and not being able to work. What could they do if they had the freedom to really come back to who they are?
You know, this is going to help me segue into a question I was going to ask later, but, you know, the question is about housing, right? There's not enough independent or supported housing for people with severe mental illness or co-occurring conditions. I don't know how you were housed, Jonah, but, you know, this questioner asked about group homes and family care homes closing down due to lack of funding, the lack of wraparound services, providing housing supports don't last long enough. Part of this is addressing the crisis of affordable housing. You know, what can lawmakers do about some of these issues?
Now, you done hit a tough subject, because even though the state get money from the federal and it goes through the housing fund and everything, most housing decisions are made at the localities, within the city, within the county. We just funnel through what the federal gives us. But if you looking right now, I think I read an article last week that it takes 4 people to rent a 2-bedroom apartment, and now these 4 people are sharing this 2-bedroom apartment, and they all making minimum wage, and that's in Raleigh. That's a $1,500 a month for those 2 bedrooms, and it's about the same in Mecklenburg County. A 1-bedroom in Mecklenburg County is going to cost you $1,400 a month. Now, these are people that don't have a disability. They are not dual diagnosed, maybe with a behavioral health and another issue, maybe substance use. They can't afford to live where they need to live. So, of course, the homeless population has significantly increased. But there has never been enough affordable housing. They have, go ahead. So they have the independent supervision that some of the IDD clients can go into. Well, right now we don't have workers. Even if you had a place, you don't have the person to go to the house and do the supervision. And normally they don't stay all day. They just go in and out. So you're not going to have that. If you don't have the workforce in place, then that's going to provide less independent living in your own apartment. So you do have some alternatives available. You have the group homes. Most kids don't like group homes. My son was in one. Most people don't like them. It's adaptive if they want to adapt to it. But also you have alternative family living setting, which my son participates in. But that's with other wraparound services, which you have to be very much aware of. He goes to work every day, but he has a job coach. They pick him up, take him to work, bring him back home. Then he still continues to be supervised. But a lot of people still are not hiring people with disabilities or maybe they just IDD, or they may have substance use, or they may have a behavioral health issue. But if they have no place to live, how do you integrate them in society? I think I saw something at the federal level. They're looking at some issues surrounding putting some limitation on renters and what independent investor companies can do for us coming in and buying up all the properties. Because we have really gone through gentrification in Mecklenburg County. I can't even, if you sell your house right now in Mecklenburg County, if I sold my house, I couldn't go buy another house in Mecklenburg County. So we're dealing with a major issue, not just for us, but we have been targeted. North Carolina has been targeted for investors to come in and do a lot of buy and flip. Some of the other states are not as bad as we are because now business looks great here, jobs look great here, but we don't look great in some other places, and so people are flocking here. And especially the younger people who are attracted to, they don't have to have a car, but they want to live next to the rail line. So it's different things that are taking place inside of our communities that we need to be very much aware of, but also demand at the city level and the county level when they're doing contracts with independent investors or developers that are coming in. You need to talk to them and tell them we want 30% affordable housing in that contract. That's what you could do. But you're not going to control an industry of private owners that are building places and saying, I can set my rate what I want to. You'll probably never see that happen. But at the city and the local level county, you have a right as a citizen to go in and say, look, we want a certain percentage of this development that's coming in our community to have 30% of affordable housing in it.
Representative Sasser, please.
We're good.
Okay, we're good. All right. Yeah, go ahead, Dr.
No, ma'am, go ahead.
We,
He's got an
although we aren't where we want to be with supporting individuals staying in their community and finding housing for individuals, we would be in an even worse place if we hadn't been forced to put in some services into the system by the settlement that we are still in. I think a decade or more than a decade with the Department of Justice that's forced development of, the kinds of services that can support individuals remaining in the community, like supportive housing, the IPS model of supported employment, our ACT teams. Eventually that settlement's going to end. We're going to have to be prepared to do all those things still, even when we're not forced to do them by the settlement, and then we're going to have to do even more. But I definitely spend some time worrying about, when this settlement ends, can we continue to choose to do the right thing when we aren't forced to?
That was my next question. I mean, because you talk about how housing is a local thing, Representative Cunningham, but, the state, DOJ forced the state into the Transitions for Community Living Initiative. Now that's going to sunset in a couple of years, right? So
right.
What can state legislators do? Because homelessness, they're also intertwined, right? It's really clear. These things are, you can't tease them apart, so you can't kind of say, well, we're going to fund mental health here, but if we don't have housing funded here, what can state legislators do?
I think right now we're on the right track in what we're going to be able to do. If we go ahead and expand Medicaid, that's going to put some extra dollars in place that we could possibly use for, because we do have the Olmstead decision that was made, and a lot of y'all may not know about the Olmstead, but the state has been working on the Olmstead. That was a decision that was made by the Justice Department for us to do certain things for that population to meet those needs. And that's been ongoing probably for 10 years now. And we're
It's going to
still
sunset pretty soon,
We've been
though.
working on it and working on it and working on it. So I think if the Medicaid dollars go ahead and come in, we will be able to do more for that particular population. But you're still going to have to, that population still is inside of a larger population that we're going to have to deal with.
Mm-hmm.
But we're going to have to meet those needs to satisfy the Justice Department in that decision. But sometimes we can go too far. Now, they've looked at some things, and now they're telling people that they want them to take their kids or their adults home out of some of these facilities, and we're going to have to look at that because families are getting upset and saying, well, they've been there 30 years, and now you want me to take them home. I'm 70 years old. And some of these places are not necessarily bad places for these people to be in the group homes. They have become their homes. And so we've got to really look at what they have made a decision on for some of the people in our communities and see if it really is going to work. And if it's not going to work, we're going to have to go back and appeal and say, look, these people are saying, we found where my child is, and now you come in wanting to upset the apple cart. I don't think so.
So just to get back to this, like a question here, Karen Dunn is sitting right here. They developed housing in downtown Carborough for people with severe and persistent mental illness, but they had to go and raise a lot of that money privately. What can the state do to support models like Clubhouse that house people, that give them support? Asking for a friend.
Well, I don't know that I'm going to be able to answer your question, but I do want to make a statement that I hope these questions and our attempt to answer them has provided the reality that these solutions are not push a button and everything gets done. And I'd like to tell people if I'd been smarter, instead of being a pharmacist, I'd have been a lawyer, made a lot more money. But I can take both sides of most issues. And on the Medicaid issue, I mean, I'm from a very conservative district, and I'm getting some pushback from my county commissioners on voting for Medicaid expansion. But they don't know what they don't know, and I can look at this fine group, and God bless all of you, but there's a lot you don't know. So these things are not easy. Now, there's a lot of problems, and we've solved 90% of the problems to get to the point where we're going to pass Medicaid. Now, we've still got CON and scope of practice and a couple things that we've got to do before we can do it. But understand, don't come to Raleigh, and come to Raleigh, you're welcome in my office anytime. But don't just come to Raleigh with your problems. Bring some solutions with your problems, okay? Because that's very important. We happen to be in the weeds. We've done health care, health insurance. We know the issues, but there's some people down there that build houses or, do this or do that. They don't know anything about health care. So don't bash those people because they don't know what they don't know. Come with a solution. Come with a story. Talk to us. You'll find most of us are actually decent human beings on some days.
Time's up.
All right, time is up. So thank you so much to our panel. I'm going to hand this back to Senator Woodard to wrap up.
Once again, let's thank this incredible panel. Wasn't it great? Thank you all very much. And thanks again to Rose Hobon from North Carolina Health News for being our moderator. Thank you, Rose. Okay, it has been a full day. We've had a full house. We're all leaving with heads full of great ideas and hopefully motivated to keep working on these great issues. So thank you all for attending the 45th Legislative Breakfast on Mental Health. Thanks to all of our speakers, to our sponsors, and all of you as participants, and of course the Friday Center staff. Wave at them as you go by the tech room or the buffet line and thank them for making all of it possible. Remember to check out the Legislative Breakfast on Mental Health website and Facebook page for information about today's presenters and the videos we posted out there as well. And there's always information on how you can contact your elected officials. We look forward to seeing you next year in 2024 for the 46th breakfast. Thank you for coming. Travel safely, and may the best team win tonight.